Greetings to everyone from Indian Society of Anesthesiologists. It's nice to be part of today's inter session with Indian Society of Anesthesiologists and also Royal College of Anesthesiologists on a different wavelength, a different platform. We will be sharing more teaching programs and more training programs with everyone. But before we start the entire event, the academic program and all, I would like to welcome our Chairman, Academic Committee, Dr. Balabhaskar, our Vice President, Dr. Suresh Bhargava, our President, Dr. Venkat Giri, and our Under Secretary, Dr. Naveen Malhotra, and a special invitees from Royal College of Anesthesiologists from UK, Dr. Ravi Mahajan, President of RCoA, Professor Mike, and Professor Sullivan from RCoA. All of them are welcome here, and it's very important this session because we are not looking at only about the bonding just because for the sake of the COVID-19 or for the current whatever the training for what we're looking, we are looking for future also. In this context, the whole discussion has a lot of importance. The way ISS handled the COVID-19 response kind of thing, and same way RCO how they handle the COVID problems in their own country, and definitely the way forward for both ISA and RCOA in planning for future collaborations in training and teaching. With these few words, I welcome all of you for today's webinar. Thank you once again. Let's follow the program. Thank you very much.
Good evening. I'm happy to be here introducing Professor Ravi Mahajan. He is the President of Royal College of Anaesthetists. He is an FRCA. He was Vice President of Royal College between 2016 to 18, and he is part of the Council till 2022. He is a Professor of Anesthesia and Intensive Care at Nottingham University Hospital NHS Trust, Queen's Medical Center, Nottingham. Actually, Professor Ravi Mahajan qualified from India in anesthesia in 1985. He came to the UK in 1988 and has since had 30 years of experience in the NHS. And during this time, he has been supporting the development of a culture that instinctively puts patient safety first in all considerations. It's a significant change in his time as a clinician. Previously, he was editor-in-chief of BJA, all of us know. And in his career as an anesthetist, he has developed and helped to develop Safe Anesthesia Liaison Group, National Institute for Academic Anesthesia, Health Services Research Center, and Center for Perioperative Care. So I'm happy to request Dr. Mahajan to present his topic for the day. Thank you very much.
Good morning or good afternoon, as it is in India, and thank you for inviting me to speak to you on this webinar. But I should also thank Dr. Malhotra for organizing this joint venture between the Indian Society of Anaesthesiologists and the Royal College of Anaesthetists. I think it is an important first venture to be able to come together and discuss something which is currently on everybody's mind worldwide, but particularly on the minds of anaesthetists and intensive care doctors, because we are very much at the forefront of the pandemic. I know that you will go through a range of topics in the coming moments, but I will start with how the Royal College of Anaesthetists responded to this pandemic when it dawned on to us earlier this year. So we started in March, and as you would have gathered, and I know in India, situation is at the moment where you are at reaching the peak or you are at the peak of pandemic. Fortunately for the other parts of the world, including UK, we are now seeing that peak declining, and I hope India reaches that stage very, very soon. What I'm going to talk about in next few minutes or so is, first of all, talk about Royal College of Anaesthetists. The Royal Colleges in the UK are quite unique, and they are slightly different from the setups such as associations or societies in the way that they work. So the main work for the college tends to be slightly differently focused, and I'll talk about that. The challenges, which is the bulk of material that I'm going to talk about that the pandemic presented to us. I'm sure that there are common themes all over the world, and these shouldn't come as a surprise to you. But what I'm going to focus on is how they presented certain opportunities for the college in the way we responded to these challenges. And finally, I would like to reflect on where we are now and going forward in the future. So the college started as faculty of anaesthetists in the Royal College of Surgeons in 1948. At the time, we had 150 members or practicing anaesthetists, you can say, in the country, 2 members of staff who were looking after the training, the exams, and the membership aspects of the faculty. Where we are now, we have 22,000 members. We house 2 faculties within the college, Faculty of Pain Medicine and Faculty of Intensive Care Medicine. We have our own building in the centre of London, and our main domains for work are lifelong learning, which includes education, training, and examination, but also continuous education going forward. Clinical quality and research. Within that domain, our main focus is on setting professional and quality standards, and that's very, very important. Once those standards are set, they undergo a NICE accreditation process. They are accredited by NICE. We also then monitor those standards through our scheme of accreditation of hospitals and departments. Research and supporting research is one of the core activities of the college. The communications and external affairs is relatively new activity that we developed within the college, but it has come to show how important it has been in the current pandemic in the way that not only we communicated with our members and our fellows, but also how we communicated and influenced our stakeholders and influenced the healthcare policy and the work that occurred during the pandemic or the surge of the pandemic and is still ongoing. So I will look at that. But let's now look at all the different organizations within the UK within which college is one, and we integrate for our functioning with all these organizations. NHS England being one, Department of Health, Care Quality Commission, many other royal colleges, in particular surgeons, physicians, general practice, and pediatricians, very, very important for us, Intensive Care Society, and all the different specialist societies with whom we work. So this collaborative working was very, very important for us when we responded, or when we are still responding in some ways, to the ongoing pandemic. Now I'll come to the main challenges. Now, these challenges are not the challenges that the pandemic presented to society in general, or the country, or the UK in general, but these are the challenges quite specific to the Royal College, to us. We were made very, very aware and very, very early on in pandemic that the NHS capacity to deal with the surge in pandemic, so the critical care capacity in particular, will be stretched. And it will be stretched in terms of staffing, in terms of supplies, would it be PPE or drugs or ventilators, things that you're very familiar with. We were made very, very aware. So we had to respond to that as to how we could make the capacity work in our favor, or to cover the surge or the projected workload that we were going to face. The lockdown in the countrywide lockdown meant that many of our things that we were conducting face to face, such as exams and training in general, and also provision of organizing events, provision of CEPD, we couldn't do that anymore. And that had to be put on hold. And we had to develop alternative ways of imparting, continuing with the training, with the CEPD, and also moving ahead with our exam structure. The whole landscape has been quite unfamiliar for many of us. And therefore, we realized quite early on that our members and our fellows will depend on a central piece of guidance, a guidance which could be adapted very easily, would be pragmatic, but guide our members and fellows as to how to work safely in this unfamiliar landscape. I talked about staff, and staff, quite early on, we were very aware that on the minds of our doctors and nurses and healthcare workers, there would be some anxiety about how to protect yourself, your family, your loved ones, but also how not to expose yourself to harm in a way that the whole system gets compromised. Because if you expose yourself to the infection and you pass that on to your colleagues, you could imagine that within no time, your whole department could come to halt. So we were very aware of that. We also were very aware of the fact that communications have to be very, very strong during this period, because if you're not communicating effectively, it just raises so many, call it fake news or call it rumors, but not only that, but also anxiety among people that just don't know what's happening and what they're supposed to be doing. And the influence on healthcare policy, so that was an opportunity, but also a challenge, because the normal NHS work was to, in some way, stop, to create capacity for this pandemic. So new policies were to be developed very, very quickly, and we were going to be part of it. So those were the challenges and the opportunities. And I'll now take each of these challenges and speak about them. I could take them as a full-fledged talk, but I will talk briefly through those, highlighting the opportunities that presented to us. So the capacity issue was quite big one for us. So we knew that normal NHS theatre activity or elective theatre activity will have to stop, and we stopped that, with the result that freed quite a number of members of staff for us who could then be redeployed in critical care area. The challenge for us was how we could cross-skill them very, very quickly, so that the things that, if they're not used to critical care, many of them were surgeons as well as physicians, anaesthetists tend to be very familiar with critical care environments, so adaptation was quicker. But for surgeons and physicians, cross-skilling was very, very important. So we developed guidance on cross-skilling, how it could be achieved. The stuff side of things, the equipment, the drugs and PPE, we worked very closely with Department of Health and NHS England to make sure that we were integrated in all national programs of acquiring the ventilators, creating extra space. You would have heard about Nightingale hospitals, which created thousands in numbers of intensive care capacity for us. PPE has always been at the forefront of where the pressure point has been. However, I must congratulate our government, the way they managed it. Despite all the shortages and the pressures, we weren't put through a phase where this was, anybody had to be going at the forefront without adequate protection. It still remains a pressure point while we are declining from the pandemic, but it is much more under control. A lot of space was created within the hospitals by shutting down the theatre activity, and therefore operating theatres or recovery rooms got converted into critical care facility. And we had to put in systems in place because this was entirely new way of looking at things, and systems became much more integrated. The general practitioners and the A&E departments or the accident emergency departments, how they worked with the anaesthetists, and the anaesthetists worked with critical care. So a lot of systems were which normally work in silos came together in a very integrated manner. So in some ways, we saw a lot of efficiency in the systems. On the other hand, systems were stretched at times when there were pandemics, when the pandemic was at its peak. After capacity, I'll now look at the challenge and the opportunities for us. So the exams had to be postponed, and because we couldn't hold face-to-face exams, but the opportunity for us was to now look at it in a way which, although always had been on our minds, but we never got around to do it, to see how a large part of our exam we could make it online, so that even going in future, the risks are lesser, but also it fits with our sustainability agenda. Redeployment, many of our trainees were redeployed in critical care facility, and with the result that they could not complete the elements of curriculum that they were to complete in the last 3 to 4 months, and we were very aware how it could impact on their career progression. So here was an opportunity for us to liaise with General Medical Council, with Health Education England, to make sure that we protected the career progression aspect of our trainees. As I said earlier, one of the challenges has been that this is unfamiliar landscape for all of us. What it meant was that organizations which normally would work on their own or within their silos, we came together very, very quickly. And the GO4 is the gang of four, the 4 organizations which were very key in providing critical care for our patients, came together very, very quickly. So these were Royal College of Anaesthetists, Association of Anaesthetists, Intensive Care Society, and Faculty of Intensive Care Medicine. We had to develop a multilateral communication among professionals. So professionals, not only critical care and anaesthetists, but also outside these specialties, so physicians and surgeons. And this required for us to develop a new website, which we got done within 48 hours. And this website then started to develop. We started to develop guidances, which were the need of the time, and still are in the process of producing some guidances, and I'll come to that later. But at the time, the guidances were required about how to intubate a patient who's COVID positive, how to look after them in critical care, and many such guidances. And there were some national guidances which were coming, and we had to make sense of it. But not only that, the gang of 4 then started to develop their own guidances. Because normally to produce a guidance, you would take about 6 to 12 months or 18 months. Here, we had to do it sometimes within 18 hours. So we needed a very fast response group of experts. So we collected 30 experts from all over the country belonging to these 4 organizations. And there was a dedicated web page and all these dedicated workforce, all these experts trying to make sense of national guidance, but also producing our own guidances. So if you go on our college website, you will see this dedicated page on COVID-19 response. And if you click on that, you will see all these clinical guidances which have been put on the website in last 2 to 3 months. These are the guidances: airway management, obstetric anesthesia. I wouldn't go through the list, but you can see how we produced guidance not only on clinical aspects, but also aspects related to education, training, and simulation, cross-skilling, but also guidances around PPE, the drug demand and supply, how you, if drugs, certain kinds of drugs come under pressure, how you then try and adjust your practice so that that pressure can be managed. And currently we are very much involved in restarting the planned surgery because the pandemic is on its way, the surge is on its way out. There is now need for us to resume the lost NHS activity, and no doubt we will be facing much more pressure on that. So much more guidance will be required on how we restart the planned surgery, but do it in a safe and effective manner. So we talked about the guidances, unfamiliar landscape training and capacity. I will just touch very briefly on staff and how the anxieties of staff we had, we encountered, and we produced a very effective channels of communications in way of weekly newsletters, setting up a new website that I've already mentioned, but we used social media, we used newspapers, we used television, we raised questions in Parliament, reflecting the anxieties of our members and fellows. And also we took all those anxieties and questions and solutions to our stakeholders. And those stakeholders, whether they were National Medical Director, we still have every week a meeting with National Medical Director, but also every 2 weeks we have a meeting with Chief Medical Officer. We have meetings with Public Health England, Chief Pharmacist, Industry, Health Minister. Very importantly, also other royal colleges and specialist societies. So we exploited our stakeholder engagement and also all the social media and every kind of media took these opportunities to highlight not only the issues, but also what the solutions are. These are some of the glimpses of many of the things or the topics that we took to national media. You can see Mike Grockert in two of these slides speaking at Sky News Centre and also speaking at BBC on various issues. And at the time, the main issue was the PPE and the protection of our members. We took it to national media. I wrote an article for Independent, as for example, and also quite a few letters to editors. But those are the kind of things or the opportunities which were provided to us. But those were the kind of opportunities we exploited in order not only to highlight, as I said, the anxieties that we had, but also the solutions, the possible solutions. But that's where our healthcare policy impact comes into action. So, in terms of our communications and impact on healthcare policies, as I said, not only we issued guidances and used channels for information, but also provided reassurance to our members. And that was very, very important. If you imagine people with anxiety about their own protection and having to work overtime in a shift kind of pattern, your members and your fellows and your colleagues require reassurance and require that support. And we were able to provide that and still continuing to provide that. We were quite effective in terms of how we prepared ourselves for the pandemic with things that I mentioned already, issuing the guidances, but also making sure that the supplies and the space and the capacity was there. Now our main issue is resuming the services, and that's where the guidance is and the stakeholder engagement is ongoing. So, in summary, our response to the challenges has been under these headings with which I started, and I will now conclude by reflecting a little bit on where we are now in the UK and what the future holds for us as we think. The graph will on this slide shows the number of daily deaths, and it takes you from the beginning in middle of March to now almost middle of June. And as you can see, there has been steady decline, although we still have some COVID activity ongoing in the community and also in hospitals, but it's not at the level where we saw it at the peak, which was in middle of April. So, although it was horrendous time for all of us, people, public, doctors, nurses, healthcare workers, country as a whole, but we shouldn't let that go waste by not learning from it. So learning at all levels, therefore, becomes incumbent, not only on society and politicians, but also on us as the professional organizations. And we should put that learning immediately into practice when we're looking at resuming the normal services. And that requires a huge amount of public confidence. National Health Service is very fortunate in a way that it commands public confidence quite a lot. But we need to retain that and make sure that we retain that, and we can only retain it when the interest of the patient is at the heart of what we do. Reserve capacity in NHS, although we created the capacity during the peak pandemic surge by shutting down the normal activity, what we are now looking at is creating a buffer capacity. So something that can be translated or that can be flexed, a resilient system, but a very flexible system, which can work either to undertake or to deal with the future, if there are going to be any surges, but also maintaining or increasing the critical care capacity, but not at the cost of ongoing NHS activity. And that is the challenge for us. And I hope that by learning at all levels, but also by putting that learning into practice, we will come out of this pandemic much stronger as an organization and much wiser as healthcare practitioners, but also as healthcare leaders. So I will end by thanking you. I know you are all in India under immense pressure at the moment, but I would like to say that this is the time when we can work together as professionals all over the world. We in the UK learned a lot from our counterparts in Europe who had pandemic before us, and I'm sure you are learning at the time of your peak in India from everywhere that you can. We are very happy to share our experiences and also learn from you as to how you dealt with your challenges. I'm sure the themes of the challenges are similar worldwide, and therefore the solutions are going to be common to all of us. But it's also time for us to support each other and strengthen our professional voice. And I'm really thankful to ISA for bringing the two organizations together, the College and Indian Society of Anaesthesiologists, to look at these issues and strengthen our professional voice. Thank you very much indeed.
Good evening, everybody. I am Dr. Suresh Bhargav, Vice President, ISA National, India. I am introducing Professor Mike. Professor Mike is Vice President, Royal College of Anaesthetists. He is BSc, MBBS, MD, FRCA, FRCP, FFICM. His term of office on council is 2016 to 2022. He is working in University Hospital, Southampton NHS Foundation Trust. Professor Mike is Professor of Anesthesia and Critical Care Medicine at the University of Southampton, consultant in Critical Care Medicine at University Hospital, Southampton, NHS Foundation Trust, and an NIHR Senior Investigator. He serves as Vice President of the College from 2019 to 2020 and is Deputy Chair of the National Center for the Perioperative Care. Professor Mike was previously Chair of the Education Training and Examination Board from 2018 to 2019. Mike graduated from St. George in 1992 and was appointed Senior Lecturer at UCL in 2005. Professor Mike was the founding director of the NIAA Health Services Research Center from 2011 to 2016. Professor Mike chaired the National Emergency Laparoscopy Audit from 2012 to 2017 and served on the Board of Faculty of Intensive Care Medicine from 2014 to 2017. He is NIHR CRN National Specialty Group Lead for Anesthesia, Perioperative Medicine and Pain and chairs the Board of National Institute of Academic Anesthesia from 2018 to 2021. Professor Mike is an adjunct professor of anesthesia at Duke University, North Carolina, USA, and an honorary professor at University College London and King's College London, UK. Professor Mike is director of the Evidence-Based Perioperative Medicine. He is chair and director Extreme Everest Oxygen Research Consortium. He is joint lead Fit for Surgery Research Collaboration. He is joint editor-in-chief Perioperative Medicine. He is Secretary, International Board of Perioperative Medicine. He is Vice President, CPX International. Professor Mike is also Treasurer, International Rehabilitation Society. Thank you.
Good afternoon. This is Mike Grocott. It's a real pleasure to be there with you. I'm sorry I'm not there physically, but these are challenging times, and I thank you for the opportunity to talk a little bit about our experience with COVID-19 and intensive care in the United Kingdom. My background, which you may have seen from the CV supplied, is as Vice President of the Royal College of Anaesthetists, but in particular in relation to this topic, I've been chairing our national guidelines for NHS England in relation to care of adults who are critically ill with COVID-19. So here is the virus, the SARS-CoV-2 virus, one of 7 known coronaviruses that affect humans, that has been causing us all so much trouble and distress over the last few months. And what I plan to do in this presentation, focusing on the critical care aspects of SARS-CoV-2 and the disease it causes, COVID-19, is address both the challenge and the response. And the challenge, I think, has been obvious to all of us. We have a disease with extraordinary epidemiology. We haven't seen a pandemic like this for 100 years or so in the world. It has novel phenotypes, so there are aspects of this disease that are much more complex than what I think many of us initially thought, which was this is similar to some kind of common seasonal flu. And it has had extraordinary political and policy and personal impact on almost everybody around the globe. The social consequences of some of the containment measures, including lockdown, have been unprecedented in modern times, arguably ever. And we all have been involved in the response to that within healthcare systems, and a number of different elements to that. One, in many countries, has been this extraordinary surge in capacity, particularly for critical care, and I'll talk a little bit more about that later. There have been changes in the style of clinical care that we give, and some simple practical things like the use of personal protective equipment, and potentially changes in clinical decision making. And again, I'll come back to that because I think it's a difficult and controversial area. So I will focus my talk in three areas. The epidemiology that we've seen in the UK, with particular focus on how that pertains to critical illness and critical care. The clinical guidance that we've come to in the UK, recognising that this is really a relatively evidence-free environment. We obviously have randomised controlled trials of patients who are critically ill, but we have very few data in relation to those who are critically ill with COVID-19. And then at the end, I'll take a little bit of time to take some reflections on, I guess, what I've learned and what many people have learned from the experience of the last 3, 4, 5 months. So if we start with the epidemiology, you will probably be aware that in the United Kingdom, we've had a very significant burden of both cases and deaths, and the measurement of this is, of course, complicated by different rates of testing between different countries. But we are clear that, notwithstanding that, we've got beyond the first surge. So both the number of cases, which surged to nearly in excess of 6,000 per day nationally at one point, and the number of deaths are now declining steadily. So we're getting somewhere between 1,000 and 1,500 cases per day now on average, and somewhere around 100 to 200 deaths per day on average. And rather distressingly, we've had a bad COVID, I think you can say. The United Kingdom, for whatever reason, has suffered disproportionately. Whether that's something about our population or our response, I don't think we'll know for a substantial period of time. But you'll see that despite being a relatively small country, we still feature at number 5 in the rankings of number of cases globally. And sadly, certainly amongst the top 10, if you look at the far right column here, we have the highest number of deaths per million population. And again, complicated to interpret this data because of different methods of measurement between country, but certainly it doesn't look like we fared particularly well in COVID-19. And there are only 3 countries globally who have higher death rates per million population than that. But our experience, I think, mirroring the experience of many countries, has been very patchy. And you can see this between countries. So some countries having barely a blip in their national mortality figures, and some other countries having very substantial differences, even countries adjacent to each other within Europe, for example. And if you look at our national map in the United Kingdom, you can see some areas, particularly rural Devon in the southwest, with less than 5 cases per 10,000 people, and other areas particularly centred around our urban hubs, so London, Birmingham, the northwest, South Wales, Cardiff, for example, more than 20 cases. And there are places where we've had more than 100 cases per 10,000. And if you look on the right-hand side of this graphic, the graph shows the burden on different parts of the country in terms of critical care admissions, and you can see that there are London in particular has been particularly hard hit, with some areas of London having more than 1,500 cases, whereas down in the bottom, the northern region of Wales has had less than 100 admissions for COVID-19, and indeed of the nearly 300 critical care units in the country, about 10% have still not had an admission. At the other end of the spectrum, several have been relatively overwhelmed and have had to transfer out large numbers of patients. So very patchy distribution. And this is the distribution over time. So we've had about 12,500 admissions of just over 10,000 patients, peaking in early April and slowly tailing off into June. But because of the relatively prolonged stay of a number of these patients, there's still a substantial number remaining in hospital. And overall, our critical care outcomes are, I think you could argue, disappointing, in that survival is only about 60% on average nationally. And with discharge from critical care, so we've got long stay patients remaining in critical care, discharge at the moment running at about 55%. But within these figures, there are centres with survival rates exceeding 80%, and others obviously with survival rates less than the average that I've shown you here. So again, huge variation, and I think there'll be a lot of interest as we start to understand this data as to why that would be. Does it relate to the population characteristics? Does it relate to the pattern of care? Does it relate to individual health systems or intensive care units being overwhelmed by a particular surge of patients at a particular time. And if we look at the clinical phenotype, most of those patients have been admitted for respiratory support, the vast majority, and of those, more than 70% for what we call advanced respiratory support, so CPAP, non-invasive ventilation, or true invasive mechanical ventilation. And most again have required cardiovascular support, with about a quarter requiring, nearly 30% requiring advanced cardiovascular support, so more than 2 or more interventions, inotropics, pressors, etc., and about a quarter experiencing renal dysfunction. And you can see on the right-hand graphic here that whether you were invasively mechanically ventilated is directly related to your chances of survival. So in green, those patients who were not receiving mechanical ventilation in the first 24 hours have a survival in excess of 70%, whereas those that do have a survival down at around 50%. So that, I hope, gives you a broad picture of what critical care has looked like in the United Kingdom. I do highlight that many of those, if you look at the total number of cases that we've had, which is somewhere between the 42,000 odd that have had positive tests and the total number of deaths that we've had, so between 42,000 deaths with positive tests and if you look at epidemiologically at the 60,000 excess deaths we've had in this time period, only about a fifth have gone to intensive care. So most patients are actually dying outside intensive care, and that maybe they're dying at home or they're dying in nursing homes. So if we move on to the clinical guidelines that I've been involved with, these have of necessity been very rapid turnaround guidelines, and they've been based on really very limited evidence because we have very few trials yet. So rather different from many of the guidelines that I've been involved with previously, where we have very extensive systematic reviews and meta-analyses of substantial bodies of literature. And the themes that we focused on within the guideline have been the following. So how to deal with the surge in demand, the extraordinary surge in demand that we've seen from the burden of critically ill patients with COVID-19. We've looked at the clinical characteristics and specific treatments, of which there have been very few, although there are a few intriguing lights on the horizon now. We've touched on clinical decision-making, which can be challenging in this condition. Of course, respiratory failure, but also the non-respiratory organ failures. And this obviously is particularly talking to the UK experience. We have had in many regions, although as I've mentioned, there are some units that haven't had any admissions. In many regions, we've had a surge in demand for critical care substantially in excess of the available capacity at the time. So if I talk to our own experience in Southampton in the south of England, our intensive care unit is a 26-bedded unit, which has, that's the general intensive care unit. We have other cardiac neuro units as well. But the general intensive care unit, which is the one carrying for COVID-19 patients, surged to nearly 60 patients capacity by taking over other units. So we put our non-COVID critically ill into our cardiac unit, essentially switched that off for a while. We took over our pediatric unit, which moved elsewhere. And at peak, we had capacity for nearly 60 patients. And that's an extraordinary logistical challenge in terms of taking over new locations, enrolling new people. So in order to staff that, we were being supported by huge numbers of freshly re-skilled anaesthetists, obviously pretty used to critical care from their training, but not necessarily doing it regularly. So anaesthetists, but also other physicians and nursing staff and allied health professionals. So lots of people being pulled in from different areas of clinical care, which actually at the time were relatively dormant because a lot of our elective planned practice was winding down because of this overwhelming burden of COVID-19. There were challenges around equipment. We were very lucky in Southampton to have plenty of ventilators available, but some centres were or ran out of ventilators. They overstressed their oxygen supply. Certainly consumables such as personal protective equipment have been an ongoing stressor, and some places have got very close to running out of that. And then these challenges I've alluded to clinical decision making, and I'll come back to that at the very end of the talk in the reflections. And I think my immediate comments on the surge is that it's been extraordinarily well managed, and it's actually, I think, probably proving harder to unravel all of that than it was to respond in the first place. And I think it was very heartwarming how personally people rose to the challenge of this sudden demand for excess critical care capacity in terms of team working and working with broader colleagues across our hospital. And this mirrors, I know, hospitals across the United Kingdom. There was an almost, and I'm not a fan of the military analogies, but an almost wartime alignment of everybody's desire to do this right. And there was a lot of mutual aid between different units within hospital and between different hospitals to help people out with ventilators or people. And I think what our reflection now is that was great. It was an extraordinary response, and I think many lives will have been saved because of that. But it is very much a marathon and not a sprint. And now we have to maintain a significant level of support for the ongoing COVID-19 burden. We have the likelihood of additional ripples or waves or surges in the future as seasonal changes in SARS-CoV-2 infection rates oscillate. And at the same time, we're restoring our normal routine services. So we almost have two parallel health services, the COVID-19 and the non-COVID-19. And that I suspect will be more challenging than the initial response. And we'll see how that plays out over the coming months and probably years. So if we move on to the clinical phenotype, I suspect you're very, very familiar with this. This is actually data from CDC in Atlanta. The dominant symptoms are, of course, fever and cough, but importantly, a number of other symptoms, including fatigue, anorexia, shortness of breath, sputum production, muscle pains, and this intriguing loss of taste and smell, which, although relatively uncommon, seems very diagnostic of the COVID-19 syndrome. In terms of patient characteristics, you will be aware that there are a number of risk factors, of which age is one. And in some ways, this is a blessing. I think this would have been a much harder pandemic if children had also been affected. And thankfully, very few, there are these rare pediatric syndromes, very rare, very few children have been affected. A real preponderance of male sex, both amongst cases and amongst mortality, as yet unexplained. Clear harms or clear problems coming in with individuals with elevated body mass index. And certainly in the culturally mixed society of the United Kingdom, to what we refer to as BAME, so Black, Asian, and mixed ethnic minorities, suffering a much higher rate of both cases and mortality. And at the moment, we don't know whether that is genetically related or whether it's socioeconomically related, because there are clearly also socioeconomic factors, as with most diseases, those at the lowest end of the socioeconomic status, those who are most deprived, suffering most with this disease. And at the moment, it's very hard to untangle ethnicity from the socioeconomic status situation. There are, of course, also a number of comorbidities, particularly hypertension and cardiovascular disease, but also diabetes, chronic respiratory disease, and other diseases that make one immunologically vulnerable that predispose to this condition. So predominantly the deaths have been in older, male, in general, larger and comorbid patients. And you can see that in our national data, but I want to show you this in a number of ways. So if you look at simple total number of deaths, you can see that there are many more male deaths than female deaths in all the age groups, going up to 85, but above 85 there are more female deaths, and that's a reflection of the fact that in our population there are many more women over the age of 85, so not surprisingly more deaths. If you standardize those rates, you can see that actually once again male deaths are much more likely per 100,000, and actually you're very, very unlucky if you die from COVID-19 if you're less than 50 years of age. Although there are some deaths, your likelihood on an individual basis is very low. What's intriguing about the ICU data is that the number of people critically ill with COVID-19 is much greater in males than it is in females, and that is true right up to the over 80s group. So there may be some bias there, which we don't currently understand, which means that we still have many more males critically ill with COVID-19, even though when you're getting up to that age group, there are more females dying. If we look at the clinical phenotype, the dominant phenotype is respiratory, with almost all patients having some element of respiratory impairment, but also significant cardiovascular, renal, thromboembolic, and I put uncertain. I don't think it's uncertain anymore, but what is uncertain is how we manage it, along with other organ systems. And I think we've come to understand that this is a multi-system disease consequent on infection by the SARS-CoV-2 virus. We've also come to understand that it's a very inflammatory syndrome. So if we look at from top to bottom, D-dimer, interleukin-6, cardiac troponins, all substantially elevated in non-survivors versus survivors. So you get in a subgroup of patients that there is profound inflammation, often associated with a tendency towards thrombotic and embolic complications, and that multi-system inflammatory description of the disease is very central to what we're seeing on intensive care. There is a feeling, there's a lot of discussion about this, but there's a feeling that there's a progression of respiratory phenotypes from an early pneumonitis phase, which is relatively easy to ventilate with relatively compliant lungs, through to a full-blown ARDS picture with hard to ventilate congested lungs, and the mechanism of hypoxemia being somewhat different between those two conditions, but the clinical management also being somewhat different. We have been really short of specific treatments for this disease. There are no specific, or there have been until very recently, no specific anti-SARS-CoV-2, so antiviral, or COVID-19 managing treatments. But I think what we can be proud of in the United Kingdom is our approach to this from a research perspective. So we've had a number of large platform trials with community-wide recruitment into these studies, and literally thousands of patients being very rapidly recruited to evaluate multiple interventions. And you can see a schematic at the bottom of this slide of the REMAP CAP trial, which was our intensive care focused platform trial, evaluating a number of antibiotics, antivirals, anti-inflammatories, including steroids. And the results of these studies, I think, will be very valuable. And indeed, I've got a couple to show you in a moment. In terms of specific candidate treatments, we've got remdesivir. We've got some data now on remdesivir as an antiviral, dexamethasone as a potentially anti-inflammatory for the COVID-19 syndrome, and also potentially having antiviral effects via the pulmonary angiotensin converting enzyme 2 receptor, and then the controversy over hydroxychloroquine and chloroquine. If we look at remdesivir, this drug, 200 milligram loading dose, 100 milligram daily, there is trial data published recently suggesting that there is benefit from remdesivir. But if you look at this slide, overall there appears to be a benefit on these Kaplan-Meier curves, certainly in those not receiving oxygen and patients receiving oxygen not ventilated. But if you look at the critical care population, it's hard to convince oneself that remdesivir is effective. So it may be that this is a drug that is more effective early in earlier phases of illness than when patients have become fully critically ill. Dexamethasone has received a lot of attention in the last few days as early results from recovery. So this was our pre-intensive care platform trial, which recruited via the NHR Clinical Research Network. So an extraordinary recruitment in 2 months of 11,500 patients from more than 170 hospitals, of whom, so multi-arm, so a number of different interventions being evaluated here, but within that platform, more than 2,000 patients were randomized to 6 milligrams of dexamethasone daily. That's either intravenous or oral as tolerated. And you can see the result here. So we apparently, and I say apparently because we've only seen this in press releases and on the Twitter sphere in tweets, we have not got a published report of this trial. So there has to be a little bit of circumspection about the data, but a very substantial 17% reduction in 28-day mortality with the greatest benefit amongst those on ventilators. So this potentially hugely exciting and very interesting because a lot of people have been using steroids of different types because of the very severe acute lung injury. So it'll be interesting to see how that has had consequences in the past, and I suspect once we see a concrete report of this, that this will really change practice. It's been challenging with all this systemic inflammation, understanding whether to give routine antibiotics or not, and to resist doing so. And I think many centres are using procalcitonin more, and we previously were not recommending routine steroids. I think with the dexamethasone data, that's clearly changed. Thromboprophylaxis is thought to be very important. There's a blank slide here for a reason. There is good evidence of thrombosis, particularly pulmonary thrombosis, some of which is thromboembolic, so presumably from DVTs, but some of which appears to be in situ microvascular thrombosis. And many people have shifted towards a more aggressive approach to thromboprophylaxis, but there's no data in this area at all. So whether that is the right thing to do or not, we don't know. It is one of the interventions being evaluated in the platform trials. In terms of respiratory failure, there's a lot of discussion about whether to invasively ventilate early or late. For those who intubate late, the use of non-invasive ventilation and or high-flow nasal oxygen has been very controversial. There have been issues around oxygen supply. So at least 3 hospitals in the UK have exceeded their total hospital oxygen supply capacity. It's not the volume, but the flow of the system, because they've had so many people on ventilators and non-invasive and high-flow nasal oxygen. So more conserving oxygen approaches, which is a mechanical ventilator, for example, in comparison with NIV, have been favoured, and we have this issue of different clinical phenotypes. And I think most people have had most success by falling back on our established, known effective managements of ARDS. So targeting tidal volumes to 6 mils per kilo, proning when necessary, all the things that we've always done. I think there's no doubt that oxygen therapy targets have been softened, and people have been much more comfortable with targets of 90 to 93% for pulse oximetry in appropriately monitored environments. And I've touched on these controversies about high-flow nasal oxygen, CPAP, and intubation. And again, we have studies coming in those areas. My centre was very much turned out to be a high CPAP NIV centre, and we have a mortality less than 20%. So we're, I think, now believers that careful use of CPAP and NIV is helpful. We don't have trial data to support that, so I would treat that recommendation very carefully. And I think you do have to have these patients closely monitored and be very willing to escalate when that is needed. There's been a lot of prone positioning going on, and we've had patients being proned and deproned for more than 3 weeks in some cases. And we've had patients on non-invasive ventilation self-proning, and that's a new approach for us. We didn't do that before COVID-19. There's been some use of pulmonary vasodilators, both nitric oxide and prostaglandins. Tracheostomy, initially people were very cautious about, but there's an increasing number of our long-stay patients who have had tracheostomies without complications. And I've touched on corticosteroids, and there is an incidence of invasive fungal infections later on, particularly in those patients who've had a lot of antibiotics, so it's worth looking out for that. I won't go into great detail about the respiratory phenotypes, but I think there's still, in terms of clinical management, there's still a useful distinction between the high compliance patients early on in the disease, who you can perhaps be a little bit more generous in terms of tidal volumes and require lower PEEP, and those who are lower compliance with a full ARDS picture who require higher PEEP. And I think we'll need to be a bit more cautious with tidal volumes and aim for an ARDS net 6 mils per kilo type approach. We've have all the usual complications that other organ failures that may need managing in the usual way, and particularly renal impairment at 25% has offered a really substantial burden on our capacity to offer renal support, and particularly hemofiltration. And there are places that have run out of some of the fluids or even devices that are related to that. So to conclude, I think one of the most interesting challenges has been clinical decision making. There was a lot of concern early on that we would exceed the capacity of the system and people would be forced to make decisions due to resource limitation. And I think that did not happen in the UK in general. It may have happened to a degree. I don't think it consciously happened, but we may have had some impact from that in those places where the highest burden was occurring. They were having to transfer patients out. So whether there were subtle differences in decision making there, less certain, but there was certainly no clear move from a do what's in the patient's best interest to a resource limitation type decision-making approach. So I don't think we crossed that line into those types of decision. We've now got very complex decisions about how to manage resources for COVID-19 and non-COVID-19 patients, how to manage infected or possibly infected or non-infected pathways between hospitals. And that's the additional burden that's coming with maintaining a COVID-19 health service whilst restoring our previous health service. The challenge at the moment for us is looking beyond the surge. I've used this expression before. It's very much a marathon, not a sprint. And I think we're looking at months, in fact, probably years. The restoration of normal services, particularly elective surgery, and the backlog of surgery that didn't take place during the COVID-19 surge is a huge challenge, particularly where PPE is required. And we're finding our way in terms of when to use personal protective equipment and when not to. I think we're preparing for the possibility, probably likelihood of resurges in the autumn, as we know that coronaviruses are typically seasonal. So we're looking at having reservists ready, so having anaesthetists and other medical and nursing and allied health professionals ready, who in the meantime can help us with post-operative critical care, but when the time comes can step up and help and be the critical care specialists in surge. We've clearly got an evolving context, a lot to talk about in terms of the societal and political change and the appalling economic consequences, which may ultimately be worse than the health consequences of this disease. And my one personal reflection is that those units that have worked best, and most units have worked very well, it's been around for all the technical work we do in ICU. It's been about communication, about clarity of communication, and we move very much to a command and control model for some time, which we're less used to here, and about compassion. So my final conclusions, it's a very rapidly changing environment. Keep up to date. There are a lot of online resources, webinars and social media information, and although we can't attend meetings en masse at the moment, I think it's very important to try and keep up to date with these things. Most importantly, in terms of critical care, is do what you've always done well. So there may be a few new interventions that come along that help, but actually attention to detail to basic critical care will be what most of these patients need. And be kind to your colleagues. It's been really tough. The services have been stretched. People are very stretched personally at home because of lockdown, children struggling with education, family members being ill or dying. And they're very stretched at work because of the burden, both from COVID and now from the restoration of services. So if I had one single reflection, it's be kind to your colleagues, try and communicate clearly, and we'll all get through this. And I'll just leave you with the signpost to these, which are the most recent version, although we've got another version coming out later this week of the NHS England guidelines. And this, which is the joint hub of the Royal College of Anaesthetists Association, Intensive Care Society and Faculty of Intensive Care Medicine. Thank you very much for listening.
Namaste. I am Dr. Venkatagiri, President-elect of Indian Society of Anaesthesiologists. It is my pleasant duty to introduce our next speaker, Professor Ellen O. Sullivan. She is a Fellow of Royal College of Anaesthetists and currently Council member of Royal College of Anaesthetists since 2016. She works at busy St. James Hospital, Dublin. She trained in UK and qualified in 1986. And since then spent 10 years as NHS consultant. She is involved in the Difficult Airway Society, DAS, since its foundation and was elected as President of DAS in November 2009. She was appointed as Difficult Airway Society Professor of Anesthesia and Airway Management in 2016, and she is the immediate past President of the College of Anaesthetists of Ireland. She held numerous posts, which include Chair of Education and Chair of Examination. She was elected to the Council of Association of Anaesthetists of Great Britain and Ireland in the year 2001 and have held many posts, which includes Vice President. She was awarded with John Snow Silver Medal in the year 2013 for her contribution to the Association of Anaesthetists. She has particular interest in working in international and third world countries with early contributions to validating what later became the Lifebox pulse oximetry project. Professor Sullivan is International Relation Officer of Difficult Airway Society, Executive Director of World Airway Management Meeting, member of the Scientific Committee on Respiration and Airway Management of European Society of Anesthesiology. She is a member at large of Society of Airway Management, an honorary member, Special Interest Group on Airway Management. With this, I present to you Professor Ellen O'Sullivan. Now it's over to the chairpersons and the speaker, Professor Ellen. Thank you.
My name is Ellen O'Sullivan and I work in St. James's Hospital in Dublin in Ireland. And I bring greetings from the Royal College of Anaesthetists to the Indian Society of Anaesthesiologists. I'm delighted to be here today to present at the Indian Society of Anaesthesiologists meeting. And I would like to thank Professor Naveen Malhotra, Honorary Secretary of the ISA, for this kind invitation. The hospital I work in is a large teaching hospital in Dublin attached to Trinity College. We do, in my clinical practice, I do a lot of head and neck anaesthesia. We have a regional maxillofacial unit and a national burns unit, and I run fellowships in airway management and simulation. Now I'm going to just tell you a little bit about COVID in Ireland. We got our first case in Ireland in the end of February, and following that there was a slow trajectory and we got our peak ITU admission middle of April, so like a 6-week trajectory, and now we're in the downslope, and in fact in the last week we have recorded no deaths from COVID, so we hope we are now unlocking the restrictions. If we look at COVID incidence worldwide, there are almost 7 million diagnosed cases of COVID-19 in over 18 countries and regions, with well over 400,000 deaths. Approximately 2.3% of COVID-19 patients will require or have required tracheal intubation. Since COVID is a very highly contagious disease, tracheal intubation is considered a high-risk procedure. And there are two main challenges for us as anesthesiologists and intensivists. We're intubating a deteriorating physiologically compromised patient, usually with severe pneumonia. And the risk to the healthcare workers, especially anaesthetists and intensivists. So we need to protect ourselves and our staff, and we need to perform the procedure while wearing personal protective equipment. Now, back in early March, we held our annual Airway Leads Day at the Royal College of Anaesthetists in London. In the UK, we have Airway Leads in every department who instigate airway teaching and on the ground dissemination of airway updates. We also have Airway Leads in all Irish hospitals. New Zealand have now introduced them, and they are being introduced in Australia shortly. At this meeting, we at short notice changed the programme to include a whole afternoon session on management of COVID from an airway management point of view. And following that, around the same time, the Royal College got together with its partners, the Association of Anaesthetists, the Intensive Care Society, and the Faculty of Intensive Care Medicine to produce information, guidance, and resources supporting the understanding and the management of coronavirus. This has been a fantastic hub and resource for all anaesthetists and intensivists worldwide, in fact. But one of the outputs from the hub were these guidelines. These were discussed at the Airway Lead Day and subsequently written up in a few days and published within 14 days. I think this is rapid publication, in fact. But these are consensus guidelines for managing the airway in patients with COVID-19. There was input from the Difficult Airway Society and published through the hub with dissemination through the Association of Anaesthetists, the Intensive Care Faculty, and the Royal College of Anaesthetists. So a lot of my talk today will be based on these consensus guidelines. There are other resources out there. The All India Difficult Airway Association has very good consensus guidelines. The Italians were very quick as well to produce, along with the European Airway Management Society, their guidelines. and other resources from the Anesthesia Patient Safety Foundation, and there are cognitive aids, and also, very importantly, there are guidelines on the use of PPE. Now, our guidance was published, as I say, in Anesthesia, the journal, and has been very highly cited with a high altmetric score. And here is just a visual of the main points in those consensus guidelines. Importantly, ensure institutional, team and individual preparedness. This is very important, to prepare for the COVID influx. Have a strategy and brief the team. And very important to involve the smallest number of staff necessary. Wear appropriate and checked PPE. Avoid aerosol generating procedures whenever or wherever possible. Focus on reliable techniques done properly. So be safe, accurate, and swift. And the most appropriate airway manager should manage the airway. Use a tracheal intubation checklist. We have recently produced those for guidelines for managing sick patient intubation in ITU patients. So important to use a tracheal intubation checklist, and a cognitive aid if difficulty arises, like the Vortex cognitive aid. Ensure all necessary airway kit is present in the room before tracheal intubation, and use clear language and closed loop communication always. The issue of personal protective equipment has been quite complicated because of difference in, I suppose, the equipment that we have been given. The WHO has given some guidance, and I think up until this crisis, and with the exception of SARS, we've had very little experience of it apart from in the movies. The Dustin Hoffman movie in 1995, we saw them using this PPE, and more recently in the movie Contagion and Pandemic. And if we look at this front cover of the Time magazine in April, we see it's the first time an anesthesiologist ever featured in the front cover of Time. And you can see that this is an anesthesiologist from Italy wearing full PPE. The new image, I think, of the anesthesiologist and intensivist. Now, SARS-CoV-2 represents a complex issue in terms of PPE. And the high reproductive number suggests that droplet spread with sizes greater than 5 micrometers can go up to 2 meters. But airborne spread with droplets less than 5 micrometers spread up to 8 meters. And direct contact with the patient or contaminated surfaces forms fomites, can survive on surfaces for up to 9 days. Bloodborne infection is not considered a prevalent infection source. Now we have seen a paradigm shift. Your personal protection is the priority when you are involved in airway generating procedures. And you need airborne level PPE. And by aerosol generating procedures, this includes intubation and extubation, front of neck airway, awake tracheal intubation, tracheostomy, bronchoscopy, using high flow nasal oxygen, using a face mask, and suction. And we know that these droplets do spread during aerosol generating procedures, so we need this airborne level of protection. And what is airborne level of protection? It involves using powered air purified respirators, hazmat suits with long sleeved fluid resistant gowns, helmets, covers or hoods, FFP3 or N95 masks, goggles or face shields if you've no helmets, and double or triple gloves are useful, particularly if they are different colours. And you can use boots or overshoes. But wherever or whenever possible, the maximum available protection level should be used to protect you. Now, these are some early pictures which colleagues sent to me from Italy, showing the PAPR equipment, showing the hazmat suits, visors, and also the importance of having someone to help you doff and don and doff. And as I said, there are different PPEs in various institutions and even from day to day, in fact, and a lot of improvisation. Now, the hub which I mentioned, the resource hub from the Royal College, has also produced some guidance on protect PPE during COVID, and a narrative review was published by Tim Cook in Anaesthesia recently. Again, this talks about contact precaution. If you're 2 meters away from a patient, you need gloves, apron, and a fluid-resistant surgical mask. And equally, droplet precaution within 2 meters from the patient. But when you're doing an aerosol generating procedure, you need all of what I mentioned earlier, including the FFP3 or the N95 mask. And remember, PPE is only one part of a system to protect staff and other patients from COVID transmission. And appropriate use significantly reduces the risk of viral transmission and infection. And it should be matched, though, with potential mode of viral transmission like contact, droplet, or airborne. Only airborne includes the FFP and the N95 mask. And remember, this is reserved for AGPs. Misuse of PPE depletes limited stocks, and it leads to avoidable shortages and increases the risk to staff. And this has been a big worry from time to time in the UK and in Ireland. Now, there are difficulties during intubation with level 3 protection. You have limited vision, so it is suggested to use anti-fog treatment, and up to 80% of anaesthetists have complained about this problem with limited vision. There are obviously psychological factors. It's very difficult to breathe with the full headgear for long periods of times during, particularly during long cases on COVID patients. Communications can be difficult. You should prepare your hand signals in advance with the team. Some people use earpieces, and a lot of people have their names on the visors to help with communication. Donning and doffing is terribly important. You must practice it in advance with a designated person to make sure donning and doffing is done in a safe manner. Now, a typical presentation of these patients is that they are often hemodynamically stable in spite of having quite poor blood gases. And this is a patient on 80% oxygen with quite poor oxygenation. But as I say, they do often look well clinically, not distressed, but with poor blood gases. A quick response is often needed as these patients can rapidly deteriorate. So there is often pressure to ventilate at an earlier stage before they deteriorate. In this article in the BMJ, the authors say they have observed patients with extreme hypoxia showing little distress. They tend to be cooperative and hemodynamically stable. However, sudden and rapid respiratory decompensation can occur. And this particular clinical presentation in COVID-19 patients contrasts with our previous experience with critically ill patients in respiratory failure, in which patients decompensated heart failure, sepsis, or massive pulmonary emboli tend to present with air hunger, dyspnea, distress, hypotension, and hypo or hypercapnic hypoxia. So this is like a silent hypoxia, so we must be aware. Now, I mentioned earlier that our guidelines suggest a tracheal intubation checklist, and that this should be done and in advance, and preparation is all important. And the logistics. There should be a team briefing, and a decision should be made what each of the roles of each of the team members is. The most expert team member should perform the intubation and inside in the theatre. An expert assistant should look at protocols and devices, and an extra person then should be available for complex manoeuvres, cricoid pressure, etc. Outside of the operating theatre, there should be a doctor available with donned PPE and another observer stroke person who will help with the PPE. Intubation should take place in a negative pressure room with greater than 12 air changes per hour wherever and whenever possible. We suggest an emergency tracheal intubation kit dump, and we had this ready for every case, and it contains all the essential intubation equipment you might need, including your front of neck box, the equipment to do an emergency front of neck airway. And you can see a picture here from a nice picture from the Italian guidelines, and you can see they have 3 personnel with PPE in the operating theatre. One is the senior anaesthetist who will perform the procedure. A second is the anaesthetist who will give the drugs and monitor the patient. And a third is the assistant who will perhaps do cricoid pressure indicated. Outside, you have an emergency assistant anaesthetist in full PPE. And I must stress that the most senior airway manager should perform the intubation. What about pre-oxygenation? As always, pre-oxygenation is particularly important in these patients, and you should place your HME filter between the catheter mount and the circuit at all times. It is not recommended that you use an ambu bag. A Mapleson C type Bain circuit is what's used. Also, positioning is very important. Using the Oxford help pillow can help. Many of these patients are obese. What about the use of high flow nasal oxygen? There is a controversy about this because it is an open system, and the high flow may generate local turbulence and driven droplets. But humidification can reduce the viral load, pressures are low, and turbulence-driven droplets are less than you get with a cough. So probably the risk with high-flow nasal oxygen is low. There have been a number of publications on this, and the more recent publications are suggesting that high-flow nasal is a low risk of bioaerosol dispersion. But overall, I think it has been discouraged. Another paper from last year showed that high-flow nasal oxygen at 60 litres per minute did not increase bacterial spreading and or environmental contamination in regular intensive care units. So yes or no? The group led by the Royal College of Anaesthetists recommends avoidance of high-flow nasal oxygen devices in order to conserve oxygen and because of the risk that it may delay intubation. Obviously, nasal oxygen during efforts at securing a tube is helpful. The no desat concept where you have nasal oxygen on, so while you are doing the process of intubation, you have some apneic oxygenation. And again, these guidelines suggest that you give a full dose of neuromuscular blockade to ensure optimal success at first attempt. Prefer that you will use a video laryngoscope and that we oxygenate with low tidal volume and pressure between attempts. It is also recommended that we use a bougie with the preloaded tube and a supraglottic airway to rescue the failed intubation if necessary. Let's look at video laryngoscopes. Which ones are recommended? In fact, it just says use a video laryngoscope, but they're all very different. We have channeled and not channeled video laryngoscopes. We have video laryngoscopes with remote cameras, and we have disposable or reusable video laryngoscopes. The AirTrack is, for instance, an example of a channeled disposable video laryngoscope, and we've used those as well as the iView. With regard to the non-channeled, we have McGrath's and some CMACs. But I think it's important to remember that there is emerging evidence that the video laryngoscope with the remote camera is best, because it significantly extends the mouth-to-mouth distance from the laryngoscopist to the patient, as compared, especially as compared with direct laryngoscopes. So VL with remote screen means you are looking away from the patient's airway, and it is safer compared, for instance, to a McGrath, where you're looking down at the patient's airway because the screen is on the scope. And obviously DL has the highest risk of being closest to the patient's airway. Now, if you can see here, this is using the glide scope, and you can see the importance of the whole team getting a view of the during laryngoscopy. And this is particularly important. Remember, if all these patients were wearing PPE, communication is difficult, space is difficult if you're wearing the helmets. So it's very important to have a remote screen. So I would say optimally use maybe the glide scopes or the CMAX, which have remote screens. Now, getting back to managing the airway, optimize success on first attempt at laryngoscopy. Basic rules, your plan A, by positioning properly, pre-oxygenation, and using full dose of muscle relaxant, with maximum of 2 attempts, because you do not want to cause the trauma and further desaturation. If you have not succeeded after 2 attempts, you're on to plan B and C, which includes attempts at face mask ventilation using the 2-person, 2-handed grip with the V grip rather than the more classic C grip, and that is what is recommended. If you fail after 2 attempts, you're on to plan B, which is about oxygenation with either the face mask or your 2nd generation supraglottic airway device. Again, maximum 2 attempts at inserting your supraglottic airway device. And again, recommended use a 2nd generation supraglottic airway device because of the improved seal and less likelihood of a leak. Here we see a variety of 2nd generation supraglottic airway devices. We tend to use the iGel, and the Supreme we do not use because you cannot intubate through it if necessary, or there are tube airway. Now, the DAS guidelines suggest that once you have the supraglottic airway device in successfully, you have a number of options. You stop and think. You don't really have the option to wake the patient up if they are deteriorating or if they're having elective surgery. You may be able to wake the patient up. You should consider intubating the trachea through the supraglottic airway device, or proceed without intubating the trachea if it was emergency surgery, or doing a tracheostomy or cricothyroidotomy. So stop and think at this point. Intubating with a fiber optic scope and an entry catheter through the supraglottic airway device is a very good technique and should be practiced in elective patients. So in the emergency situation, one is experienced at doing this. And in the case of the COVID patients, you would use a disposable ambu scope, and the slim ambu scope fits, the entry catheter fits nicely over that. And remember, if that fails and the supraglottic airway device fails, you need to think about early front of neck airway in the can't intubate, can't oxygenate scenario using a scalpel bougie tube technique. And I showed you the equipment dump kit at the beginning. That should contain scalpel bougie tube to perform a front of neck approach for a can't intubate, can't ventilate scenario. And remember, we will still get our difficult airways, and we have been doing a lot of difficult airway cases during the COVID period. So we have done awake tracheal intubation on these patients, either using a flexible bronchoscope or a video laryngoscope. And we follow the recently published Difficult Airway Society guidelines for awake tracheal intubation, which were published and presented at the WAM meeting in Amsterdam in 2019. And they follow the principles of 4 important steps for success. Important to get the sedation right, the topicalization right. Obviously, oxygenation is very important, and your procedural skills. So if you get those 4 elements correct, you will have a successful awake tracheal intubation. With regard to COVID patients, it's even more important to get the sedation right. We use remifentanil. It's a very good antitussive, and you really don't want these patients coughing. So you use remifentanil from 2 to 3 nanograms per mil, and maybe a little bit of midazolam if they're very anxious. But remember, they might be hypoxemic, so you have to be very careful of your sedation. But equally, start the remifentanil in advance of topicalization to minimize coughing in these patients. Very cautious topicalization, and you would avoid nebulization in these patients, and you have to perform it very gently to minimize coughing. We use this MAD device, which has a nice gentle spray, and you do it gently and slowly in these patients, particularly in the COVID patients having elective procedures. Remember always that capnography is essential to confirm endotracheal position, and you should have capnography on your face mask and available. With your PPE, it's very difficult to use a stethoscope, and in fact contraindicated. So use capnography to confirm placement of your ET tube. And remember to avoid circuit disconnections. And if you need to, you can use clamp the endotracheal tube if you have to disconnect. Remember also, you're often putting in central lines in these patients. You will have ultrasound, so you can check the position of your tracheal tube using ultrasound. So what about an intubation box? There's been a lot in the media about these Perspex intubation boxes, which have been created by for lots of healthcare workers, and it's even been in the news. Now, these may have advantages, but there's a lot of publications suggesting that perhaps they are not as good as we think, and they can limit your physical accessibility to the patient. But there have been lots of them made available, lots in Italy and in other places. In pediatrics, people have been using these plastic sheets and also these intubation boxes. Now, I looked at the All India Difficult Airway Association consensus guidelines as well, and they are excellent. They suggest that the patient should be covered with a transparent plastic sheet or a customized intubation box. But there is some worry that, as I said, it decreases rather than increases safety. What about supraglottic airway devices? The information hub from the Royal College of Anaesthetists does make a statement on this and says there is lack of evidence, but there is no reason why there should be a change in standard airway management during anaesthesia in COVID-19 positive patients or unknown patients. But recommend that if a supraglottic is used, it should be second generation, and that scrupulous attention should be paid to ensuring a leak-free seal. Now, as I mentioned, we have this Airway Lead Network, and they've played a very important part in the preparedness of institutions for COVID. They have instituted the guidelines that have been published, and they have instituted local training because, as you can imagine, all the usual training workshops that are run regularly, regionally, and even in the college have not been happening because of the 2-meter distancing rule and difficulty getting people together. What about the COVID risk in healthcare workers? There's a lot of work coming out on the numbers of healthcare workers who have been infected in China, in northern Italy, 15% in Spain, and 7% of healthcare workers in the UK were off work at any one time. So what about healthcare workers particularly exposed to tracheal intubation, like anaesthetists? We set up this registry called Intubate COVID Registry. In fact, it was 2 anaesthetists in Guy's and St. Thomas's who started the registry, and many of us now have joined. And we published some of the early data from the registry just in the last week. And this is just an infographic of some of the highlights of the paper. Tracheal intubation is thought to pose the greatest risk of nosocomial transmission to healthcare workers, as we've said. And to date, over 1,700 healthcare workers from over 500 hospitals in 17 countries have reported 5,150 tracheal intubations, and this is still going up. 1 in 10 reported a positive COVID test result or symptoms suggestive of COVID infection. And the symptoms they reported were fatigue, cough, and half reported a sore throat. 8% reported symptomatic self-isolation and 3% reported lab-confirmed COVID infection. The risk varied by country to country, but was higher in females, but was not associated with any other factors. And half of the tracheal intubations were performed in critical care units. Now, 88% of the tracheal intubations were performed with participants wearing PPE, confirmed to the WHO recommended minimum standard. And this information should inform decision-making, we think, and planning of safe and sustainable delivery of healthcare services globally. Now, if we look at the countries that recorded the most cases, the UK was top of the list there, and India recorded 338 of these intubation records. And this is a picture of Imran Ahmed and Kareem al-Baghdadi, who were the main instigators of this registry. So remember, 8.4% symptomatic self-isolation of anaesthetists and intensivists, and 3% with lab-confirmed COVID. And 12% of the healthcare workers who performed tracheal intubation in patients with COVID did so without PPE that was deemed sufficient. Now, looking at the data, we found that 80% of all intubations were done with video laryngoscopes and 20% done with Macintosh laryngoscopes. So the Macintosh laryngoscope is still out there and being used. Fiber optics were done in 0.7% of COVID patients. Number of attempts were limited mainly to kind of 1 to 2, and nobody was persisting with multiple attempts, which was good to see. So can I encourage you all to get on the intubatecovid.org website and log your intubations. And by doing that, you can build up your own log, which is very useful to look back on. It's very quick to complete. You get an email each week asking you about if you have any symptoms or any diagnosis of COVID. And we can compare all country results even more and look at variations in PPE. So we're continuing to gather data, and we will republish further data down the line. So I think my take-home message is COVID-19 airway management must be safe for patients and safe for the staff. It must be accurate, avoid unreliable, unfamiliar or repeated techniques. And it must be swift, timely, without rush or delay. So can I wish you all the best in managing this group of patients. And I would like to thank you very much for the invitation again to speak to you at the ISA meeting.
Good evening, everyone. Greetings. We're happy to be part of this particular webinar between ISA and RCoA. And the most important thing is today I'll be sharing with you our ISA thoughts about the COVID-19 pandemic. The first case in India about the COVID-19 problem we registered somewhere around the last week of January, and the government was keeping a watch, and so as ISA. And subsequently, by the first week of March, the government started sensing that it might achieve the higher proportion and all those things. They started doing the restricting the gathering and all those things from March 11th onwards, and it was imposed, and then subsequently the government of India announced a complete lockdown from 24th of March, and it almost about 4 to 5 lockdowns we are already going through. And currently India is in unlock phase 1, and also the phase 5 lockdown also is going on. We're just trying to balance it out. But one thing is the lockdown definitely helped the country in setting up the COVID care centers, COVID health centers, COVID hospitals, COVID ICUs, and of course increasing the ICU. But basically it could help the government in scaling up the resources like PPE kits, testing kits, manpower mobilization, equipment, and other resources. And it was much needed for our country. The kind of whatever the limited GDP what was going on health sector, definitely it has helped the country in a bigger way. In this context, the Indian Society of Anaesthesiologists responded swiftly and postponed its academic program in different parts of the country because we could smell by the end of the first week of March that the pandemic might achieve a bigger proportion. So by 13 March 2020, we sent an advisory to all the city and state branches, and of course, national body, postponement of all the ISC academic programs and also official meetings. The reason being because the government already restricted the gathering and all those things. It will not be safe for anyone. And before we could understand what could be the size of the pandemic in India and all those things, the precautionary thing what we wanted was first of all not to conduct any program. Yes, we had to postpone and cancel some of the active programs at Karad in Maharashtra and at Lucknow in UP and Delhi State Branch, Rishikesh in Uttarakhand, Aurangabad, Maharashtra. It was a tough call, but of course that branches and went through a tough time and all those things. But the safety of our members and other people was most important. On that basis, this advisory sent the 13th March. Before any society could send, we were the first to send the advisory to all the members. Please stop and till March 31st, all the programs. Subsequently, once it happened, then subsequently we had to postpone our own alternative meetings also, like the ISA Governing Council meeting was supposed to be held at Shillong, Meghalaya, and that also we said to be postponed. And also ISA Registered Office, which is supposed to be done at Chennai, because we have that's a new office what ISA National Body wanted to have it and all, but the finalization process and all was also deferred in view of the pandemic because members couldn't travel because lockdown was imposed. ISA gave the first national advisory for statement on 23rd of March 2020, and in fact it came almost one day before the lockdown was announced and all those things. This about the do's and don'ts for all the anesthesiologists about how to go about the whole issue and what to do, what not to do, how to take care of themselves, their patients and their family. And at the end of the most important thing was how to serve the country was depicted in this particular advisory. And following this, 3 days later, we had a ISA webinar for anesthesiologists of India. And because the idea was because this is a pandemic which none of us have seen, our generation definitely has not seen. And there were almost close to about 10,000 viewers who were there. And that itself says that like people wanted to know about the program because as of today, as we are discussing and all those things, already the pandemic has crossed more than 8 million across the globe. And the deaths are around close to 5 lakhs. And in India, if you're talking about it, today, well, we are already crossed about more than 3.5 lakh like infections and deaths are more than 10,000. In this situation, all these events were very important to take care of our members and alert them, educate them so that we can take up the challenge. That's most important because at the end of the day, we are the warriors who take care of these things, whether it's in the emergency area or maybe in the ward area, in the intensive care area or operation theatre. We are always there and we have to be there. Once by March 31st, we realized that like lockdown was extended, all those things. We released one more update on 1st of April. This advisory was for all the city and state branches and all to defer the activities till further orders because we were not sure how long the pandemic will be going on. And all the activities, whatever was being planned, we said please do it online as much as possible. Have web meeting, have webinars. That's much more encouraging rather than having a physical kind of like meetings. We came the second advisory on 11th of April. This was regarding the use of PPE kits and all, masks and face shields by the anesthesiologists because they had to know because there are a lot of short supply in the country because suddenly the pandemic came and the raw material was not available and we had to import it here and there. There are some difficulties for members to get it and all those things. Again, do some don't. The first experience for everybody to go for the doffing and donning. So we had to spend a lot of time in educating our own members. And second problem was availability of PPE, masks and face shields for anesthesiologists and all. So we started identifying the vendors at the city level, state level, and all those at national level who can help out our members because at that time the transport was blocked because we couldn't transport anything. We said don't think about something comes from Delhi or some other higher center. Please procure at your local level. We started identifying the local vendors with the help of the local city and state branch, our own ISA members. The third thing what ISA did for was one of the most unique thing what which is unheard most of places is we released the grant in aid well in advance for buying the PPE masks and face shields for our ISA members so that they can be safe and almost close to 70 lakhs has been released so far to take care of our own members for all the problems what they have, because unless they are safe, the country can't be safe. That was the whole motto. So we mobilized all the state city branches, and many state city branches, they also pumped in funds from their own local sources and all, and to make all the anesthesiologists their own city branches to be safe and practice a safe anesthesia, so that if we have safe anesthesia, we can have safe country. The fourth challenge was this was part of the ISA, but second thing is we had to speak to the stakeholders in the government, whether you talk about the policy makers or the ministries or probably the Prime Minister's office and all those things. In this part, like a lot of advocacy efforts were put in, and we had to interact with the Niti Aayog and Medical Council of India, Ministry of Health and Family Welfare and IMA, and we had to share the database with the Government of India because they wanted to have the list of anesthesiologists working at the state level, city level, and also at all levels, so that they can have a COVID warrior team, so that in case of emergency in that particular area, the local healthcare officials can take their help. So that's an ongoing thing, and also apart from that, the government seeks the help of ISA in probably planning out the COVID operation theaters, and also the how to go about mechanical ventilators, and about the training the manpower in handling the ventilators or for the COVID emergencies. So it's an ongoing which is going on, and ISA has emerged as a big stakeholder with respect to handling COVID-19 in India with Government of India. And of course, we also formed our ISA National Task Force, so that we can help out our members at the local level and all those things. And always, all the people are told most important thing is think globally, act locally, keep watching yourself, look the global trend how it is going on, so that you can handle the local problem. So we have the clinical coordinators, training coordinators at the zonal level, at the state level, city level, who can help out any member anywhere, anytime, and also healthcare officials. And this is the strength of ISA grassroots level, and that's what being appreciated by everybody. They say the ISA is such a strong force in the ground level that nobody can match it, and because our people are there, no corner of the whole country, and that itself is a tribute to all our members, and we salute them. We came with the COVID operation theatre advisory, and because by 29th of April the numbers were increasing and emergencies were happening and all those things, still we had to handle, and all the kits were not enough and all those things, but we had to take up the COVID cases, suspect or confirmed, so we couldn't refuse. So we released the COVID operation theatre advisory, and that was for 29th April as such. That was very well appreciated by not only within the country, outside the country. We can just see on WFSA has put the COVID or advisory COVID operation advisory on its website, so that it can be populated amongst all the members whosoever is interested in adopting these particular thoughts. And also we had to look at that, we are not only looking global, at local level also. IMA, that Indian Medical Association, also has put the COVID advisory on its website, especially COVID OT and all, because a lot of surgeons are also part of it. The idea is to make the country safer and to help out our own professionals. That was a big challenge, and we could achieve it to a larger extent, and because in Government of India also looking at the standards, what is being advised by the Indian Society of Anesthesiologists. And we had a webinar with IMA on 2nd of May, because they wanted to train the IMA members, because in handling the COVID emergencies or probably handling mechanical ventilation for the short time, whatever time they had to handle and all, or maybe oxygen therapy, airway management, these things they wanted to understand and all. In that context, we had a joint collaboration with IMA, and in that one, almost viewers were more than 7,000. So that's a big number. That's the demand that has been created because of the persistent efforts from all the ISA governing council members, not only at the national level, at the state and city level, and of course all the corona warriors of ISA. And icing on cake was the IGI supplement on COVID-19 was released by Indian of Anesthesia. The most important reason being because the supplement had all the way of all the things with relevant to COVID, how to identify, how to manage, and how to take in the prognosis and other things, and everything was spelled out in this particular supplement, which has been quite useful for all members across the India. Not only India, because it's a free access journal, anybody can access it across the globe. So it's very important. We had a multi-pronged approach with respect to not only the society level, at the national or city or state branches, and not only at the academic level with the journal and all those things. Definitely we are going with the Government of India, the policies and all. And of course, the state government had some variations. We are also party to that particular one. The most important thing is this kind of pandemic always puts stress on the members. So to overcome the stress and to motivate, galvanize, the refresh and de-stress our own IS member, we launch a lot of programs which can motivate them, who can they can make up their mind to take up the newer challenges. We started ISA Fit Anesthesiology campaign, then ISA Culture Club, ISA Art and Literacy Club, ISA Social Outreach Program. And of course, most important, we started reaching the unreached because there are many of our members who are there in many places where there was no city branch, state branch. So we request the local city and state branches, please reach out to members who are not part of ISA, any kind of branch and all, but at the end of the day, they are our colleagues, they are our friends. Without them, we are nothing. So a lot of effort went in. The ASA Star campaign almost happens every day. Every day, a new star is identified for his personal efforts or institutional effort or a group of members and all. The appreciation goes on and that motivates people and that keeps up the spirit. Because it's always said when the going gets up, the toughs get going. So that's what we believed. We kept on doing a multi-pronged approach. And probably at the end of the day, we are happy still, probably a lot to do and like miles to go before we rest. But we again would like to re-emphasize, please wear masks, do regular hand wash and maintain social distancing. Let's work together to maintain health of our great planet Earth. Again, I stress on the Think Global, Act Local slogan of WHO, which came sometime in 1980s. But most important is work safely and stay healthy. And thank you so much. Thank you once again. Have a great day.
Good evening. Today I shall be discussing about elective surgery in COVID pandemic, the must changes in anesthesia practice. I bring with myself greetings from Department of Anesthesiology and Pain Management Center, PGIMS, Rohtak, Haryana. In the current COVID pandemic, patients may have to undergo surgical procedures under general, regional, or local anesthesia. Such surgical procedures necessitate the must changes in practice of anesthesia in the current COVID pandemic. I can stress that these changes are very, very simple, but we have to follow the ISA advisories and other advisories and position statement consistently, consciously in all anesthetics. These are the simple measures with big impact in the current COVID pandemic. First, the pre-anesthetic checkup. There should be a preliminary screening at reception where the history of fever, cough, sore throat, and other symptoms is elicited. The temperature is checked, and travel history is also elicited. The patient is wearing a face mask all the times, and patient and their attendants and all the healthcare workers follow hand hygiene measures regularly. Detailed PAC is mandatory in all patients while maintaining physical distancing and hand hygiene. Patient should wear a surgical mask throughout his length of stay in the hospital, whether he is in PAC or ward or in the OT. And also the one attendant, which is usually allowed with such patients. There should not be a group of attendants along with the patient. Pulse oximetry is the new norm in the pre-anesthetic checkup. Always assess the pre-operative oxygen saturation by using pocket pulse oximeter. There are concerns about aerosol generations while you are auscultating the chest and exposure to the aerosols or droplets. For that, a digital stethoscope has been there where you are away from the patient. Recently, an innovation came using stethoscope with an audio recorder, with the recording can be done on the mobile phone. Or if nothing is available, you can auscultate the back of the chest with patient's face mask on, and the doctor is standing at the back. And after every use, and also we always evaluate the X-rays very, very carefully, but we should be more careful, especially in this COVID. There are again concerns about airway assessment and exposure to the AGPs. So mobile phone camera, the zooming techniques have been used, but still more innovations are required. Use of RCoA app launched by Government of India is to determine the risk if one has been near, that is within 6 feet of a COVID-19 infected person. So this app can help us while using the location information to determine whether the patient belongs to one of the infected areas, the so-called hotspots. Rational use of PPE is to be done for OPD, like pre-anesthetic checkup clinic. It falls under the moderate risk category as per the Ministry of Health and Family Welfare guidelines. So the anesthesiologist should be wearing N95 mask, gloves, face shield, visor, or goggles. As examination of oral cavity and dentures is a mandatory component of all pre-anesthetic checkups of the patients undergoing any surgery. So the doctor should be wearing N95 mask, gloves, face shield or visor or goggles. The elderly patients and patients with comorbidities, we should discuss in detail with them and their attendants, along with the surgeons, whether the elective surgery can be done when the surge and second peak of pandemic is over. Rather, we should do a counseling for them to get these surgeries done at that particular point of time. Coming on to the pre-procedure testing. What is the need and why it should be done? Basically, it serves two purposes. One, to protect the healthcare workers getting infected from a patient who is suffering from SARS-CoV-2 infection. So it is a measure, and also to decrease the morbidity in patients, because there have been numerous reports of increased morbidity in COVID-infected patients who underwent surgical procedure. So the pre-procedure testing, should it be done in all patients undergoing surgery? Ideally, yes, it should be done before all surgical procedures, because the vast majority, up to 85% of the patients are asymptomatic. Especially if the patient is symptomatic, is a native of hotspots, there is a travel history, patients who are of old age and with comorbidities, the pre-procedure testing becomes more important. But all said and done, that it should be done before all surgical procedures and this target and aim can be easily achieved? No. There are challenges because of limitation of capacity of testing, challenges because of limitation of number of testing facilities, the delay in availability of the report. At times, patients are also reluctant to get the testing done. There are economical issues also, and some stigmata is also associated. The test which is usually done is RT-PCR, which is gold standard. Different machines, TrueNet, UBNet, open systems are available for qualitative detection of nucleic acid from nasopharyngeal and oropharyngeal swabs. But there may be a possibility that when you do an RT-PCR, patient may be an incubation period. So, should we get a repeat RT-PCR done after 5 to 7 days of surgery? In daycare surgery, this is not possible. Probably this is possible in patients who are admitted in the hospital, who have a prolonged stay in the hospital. So, in them, this test is possible after 5 to 7 days after surgery, just before discharge. Then there are other concerns also. Suppose a RT-PCR is done, it turns out to be negative, and surgery has to be done after suppose 5 to 7 days. So patient may become infected or may get infection during that period from other contacts. So in that it is suggested that if time permits, testing is done and patient is kept under isolation at home or hospital, and then directly comes to the hospital for surgery. Few days ago, ICMR has advised the standalone antigen detection assay, standard Q COVID-19 antigen detection kit. In this, only nasopharyngeal swab is required. The test has to be completed within 1 hour and it has got a very high specificity, 99.3 to 100% specificity, and sensitivity is between 50 to 84%. So ICMR has recommended the use of standard Q COVID-19 antigen detection assay as a point of care diagnostic assay in asymptomatic patients undergoing aerosol generating surgical or non-surgical interventions for both elective and emergency surgical procedures. So the antigen testing will help us in both elective and emergency surgical procedures and in both aerosol generating surgical and non-surgical interventions. So we have got now an official recommendation for a pre-procedure testing. But it comes with a rider that suspected individuals who test negative for COVID-19 by the rapid antigen test should definitely be tested sequentially by RT-PCR to rule out infection. So, though it has got a specificity of more than 99%, but still if your clinical suspicion is that the patient has got history of cough, fever, sore throat, diarrhea, abdominal pain, belongs to a containment zone, hotspot, or has got a history of travel, you can definitely go for RT-PCR. But a positive test should be considered as a true positive, and that does not need the reconfirmation by RT-PCR. So I am very sure that this test will be available very quickly in all corners of India, and it can be done, and it will solve a major problem for elective surgical procedures. There is a concern about personal protection equipment and pre-procedure testing. There is no doubt about that personal protection of healthcare worker is most important, more than COVID testing. So even if you got a pre-procedure testing done, but there should not be any compromise, any relaxation in personal protective equipment. And as per the ISA advisory, PPE for all anesthetics includes changing your OT clothes, wearing a cap, N95 mask, face shield, wearing a shoe cover over an OT sleeper or wearing gum shoes, gloves, and liquid impervious gowns with long sleeves. So these are mandatory for all anesthetics, and nowadays the gowns are becoming easily available, who are washable or sterilized with UV light. In the operation theatre, only essential items and gadgets should be used inside the operation theatre. No extra gadgets and items should be there in the OT. Similarly, the surgical equipment, linen and dressings, which are essential to be brought in the OT after induction of anesthesia. Regional anesthesia is preferred wherever possible. The spinal anesthesia, combined spinal anesthesia, nerve blocks, USG guided or PNS guided, they are preferred wherever possible. In case supplemental oxygen is required, the oxygen can be applied over the surgical mask or the N95 mask placed over the patient. Sedation during general anesthesia is a bit controversial, but at the end of the day, it should be preferably avoided, because if the patient becomes over-sedated, there are concerns about airway obstruction and subsequent airway manipulation, which may lead on to generation of aerosols and droplets. In the OR, there should be minimum number of personnel so as to avoid them exposure to the aerosol generating procedures like intubation and extubation. For this, anesthesia can be administered in anesthesia procedure room if it is available. If it is not available, the rest of the OT team should be scrubbed and ready, and they can come inside the OT after the aerosol generating procedure is over. The art and science of low flow anesthesia will be more pertinent so as to decrease the OT pollution in this COVID pandemic. Closed circuit ventilation is the new norm, and high flows are to be avoided to decrease the aerosolization. The freelance anesthesiologist should emphasize the surgeons for purchase of anesthesia workstations with ability to deliver low flow anesthesia and closed circuit ventilation. Also, a closed airway suction system is always preferable. Heat and moisture exchanger with viral and bacterial filters. At least two HMEFs are placed, one between the tracheal tube and the breathing circuit, and second between the expiratory limb and the anesthesia machine. A third HMEF can be placed on the tracheal tube itself or on the inspiratory limb of the anesthesia machine if it is feasible. Video laryngoscopes are preferred for tracheal intubation. They serve two purposes. They increase the distance between the patient's airway and that of anesthesiologist, and they also improve the intubation success rate and avoid multiple attempts at tracheal intubation. A word about aerosol containment box. It can be used which are made up of acrylic plastic sheet if available and feasible. But there is plenty of literature in favor of and against the use of such boxes. But one thing is very common, that there should be a negative pressure inside the box always. Near modifications are coming regularly regarding this aerosol containment box, intubation box, extubation box, and one thing is also more important is that there is a learning curve. So initially you may find that a simple intubation has become a difficult intubation. So it is always suggested that do some hands-on on mannequins before using this containment box in patients. Total intravenous anesthesia may serve as a potent tool if practiced safely. Daycare anesthesia and daycare surgical procedures are definitely preferred. About the scavenging, active scavenging is not available in majority of the hospitals. So where it is not available, we can go for passive scavenging with the help of corrugated tubing or duct which is attached to the back of an anesthesia machine, and the exhaust air is let off into the atmosphere through an upward plume at a height of 3 meters above the tallest point of the building. The corrugated tubing has been applied to the scavenging coat, and it can be dipped in a bucket with 1% hypochlorite solution so as to bubble through the gases through the hypochlorite solution. But evidence is lacking regarding the contact time of the gases and the theoretical risk of increased heat. Air conditioning. See, normally ORs are maintained in positive pressure that results in an air bleed from the OR to the outside. So this has been done to prevent infiltration of contaminants into the OR. But however, in the COVID scenario, it is totally reverse. We have to ensure that there is no spread of infectious agents from the OR to the outside. So we have to alter the pressure in the OT. So ideally, there should be a central air conditioning unit with the ability to alter the pressure, making it neutral pressure or negative pressurized. There should be minimum of 20 to 25 total air changes per hour, including 4 fresh air changes per hour. Laminar airflow with independent air handling units and HEPA filters at the exhaust are the ideal scenario. And there should be a 30-minute time between each case for air exchanges and for sanitation and decontamination as per the standard guidelines. But if these ideal circumstances are not available, then you have to apply 2 split air conditioners of 2 tons refrigeration capacity each OT, and there should be a fresh intake through a fan filter unit. This fan filter unit is required to prevent the outdoor dust entry and to prevent the OR contamination. And 2 exhaust fans of the industrial grade are applied to create a negative pressure inside the OT from 2.5 to 5 Pascal. So this is the OR which is at a negative pressure, and all the air is set in because of the negative pressure, and this OT is there is an exhaust applied and all the gases are going here, and the exhaust air is treated with HEPA filters, across the HEPA filters, or through chemical disinfection, or through heating, or through UV radiation. These are the 4 possible scenarios which are available. Another thing which has been suggested by Ishre is that you keep the OR at positive pressure, but the adjoining room becomes negatively pressurized. So you are working in OR at positive pressure and ensuring that the OT sterility is not compromised. And the adjoining room, you apply the exhausts, and this becomes the negative pressure, which sucks in the gases from the OR as well as from the wards or corridors, and then subsequently this is exhausted. But this also requires a major change in infrastructure. The third thing which has been suggested is having a negative pressure hood on the patient's head and neck. So this negative pressure hood, it also sucks in the air and it is then exhausted through the exhaust unit. To set the room air temperature between 24 to 30 degrees and maintain relative humidity between 40 to 70 degrees. A word about laparoscopic procedures. We should suggest our surgical colleagues to limit the use of, they should have limited use of low energy devices so as to reduce the viral load, and they have to be preferred at all times. The desufflation of pneumoperitoneum must be performed by an appropriate suction device attached to a HEPA filter to prevent venting into the operating rooms. And some surgeons have tried treatment of desufflated air through the hypochlorite solution, that is bubbling through the hypochlorite solution. Telemedicine may have a beneficial role, especially in pre-anesthetic checkup and as well as for post-operative rounds, including post-operative pain relief. So this is a new horizon. Now it has been legally allowed also by the Board of Governors in supersession of MCI. So this is a new horizon for the anesthesiologists of using telemedicine in PAC as well as for post-op pain relief. Last but not the least, please do not carry the infection at home. Cover your mobile phones with transparent plastic pouch while in hospital. And when you do take care of your daily use articles like bags, purses, and when you go back home, use the outermost washroom of your house. Remove your shoes and clothes and shower. Take a shower as soon as you enter your home, because you not have to take care of your own health to serve the patients, but you have to take care of your health of your parents, your siblings, your spouse. Then only you will be able to serve the society. To summarize, it is re-emphasized that wear masks, do regular hand wash, and maintain social distancing. Let's all work together to maintain the health of our great nation, India. Work safely, stay healthy. Thank you very much. Long live ISA. Jai Hind.
Professor Ellen Sullivan, Dr. Suresh Kumar Bhargava, Dr. Venkatagiri, and of course Dr. Naveen Malhotra. We also have Professor Mike Grocott. Welcome to all of you for today's webinar, basically in the form of a panel discussion. So just to recap and restate, of course, skill, if you talk about the skill in any field, it is a type of work or activity which requires some special training and knowledge. And especially when we talk about somebody getting specialized in anesthesia as MD or DNB or diploma, so we are actually educated, we read a lot, but ultimately when we talk of going ahead and practicing anesthesia, we are expected to gain certain skills. So these skills are the ones which are going to help us in active patient management. And implementing the knowledge for practice, of course, therefore depends upon the training or the lack of training. And this has become very obvious in the current pandemic season. And we in India, as was probably previously discussed by Dr. Mahajan, we have got almost, we are getting into the peak of COVID now. We have got more than 35,000 members of Indian Society of Anaesthesiologists, and there are at least 15 to 20,000 outside of ISA even now. So the reason that we have picked up this topic is, yes, we have got certain programs running, and we have got Medical Council of India also working on the skills in practice and in education. But we also want to exchange with our colleagues in RCoA what is on offer with respect to the skilling of anesthesiologists. And of course, if you can remember one of the projects which is launched by the Prime Minister of India, Skill India program, which was launched about 4 to 5 years ago, so that all the our citizens across all the fields get trained with skills, so that they can their efforts, their labor can be put into better use. So I would like to start the program by addressing Dr. Venkatagiri, the President-elect of IS National. I just gave a background, Dr. Venkatagiri, but how important is actually the skill in terms of medical education and particularly in the field of anesthesiology?
Thank you, Dr. Balabaskar. Skill is very important to do any job perfectly. It is more so in medical services or medical, because we don't have time between the production and delivery. Healthcare is called as an industry. But in any industry, there is a time between production and delivery. If there is anything wrong goes, you can correct it. But here we cannot do. More so in anesthesia, because we have only 3 minutes time between life and death. So we should be perfect in doing any job. Now, I've seen many people in this COVID season who are not able to manage the airway perfectly or to do ventilation. So if you have a good skill, you can manage the patient perfectly and come out with them and give good. When the Medical Council of India, in the recent development in the last year, you can see in the website, had made that given a lot of importance to skill development, and they have defined different skills for MBBS graduates and for the PG graduates. For MBBS, they have told he has to do this much. He has to observe, do, and assist. These are things which has. Even the preamble itself, the Medical Council of India says that an anesthesia postgraduate should do this much work. He should have the knowledge of the anesthesia practice. He should attend the conferences, CMEs, acquire the knowledge, and it has more so defined that what he has in the first 6 months and the next 2 years and the final 6 months. The government has given a lot of importance to skill both for MBBS and this thing. So skill is more important to do our job perfectly, to become independent, to manage any case. You should develop sufficient skill. That's what MCI also says in the preamble and in its curriculum. He should have perfect skill. He should be able to manage cases properly. This is what.
So that's in fact, as far as I know, basically, even the individual universities are given liberty to go ahead and update the parts which are related to the skilling of the MBBS doctors as well as postgraduates. And overall, yes, the document is very good and the intentions are good. But I want to know from Dr. Suresh Bhargav, Vice President of ISA, are you satisfied that these are actually getting implemented? Are there any improvements overall in the Indian teaching institutions with respect to the skill being important to the trainees?
I totally agree with Dr. Venkatagiri, but definitely the MCI initiative is very good. These are really good if you go through the documents related to anesthesia PG training. But as usual, we are slow in responding. And these norms are not implemented in all the PG institutions. Probably in about half the PG institution only, these norms are implemented. And why these are not implemented in the rest of the 50% of the institution? First, either there is no facilities or there are ill-educated trained staff to implement the MCI norms in letter and practice. Apart from this, many teaching institutions are attached to civil or general hospitals. Their workload of patients is very high due to population or other political reasons. Time spent on teaching is not appropriate and MCI norms are not followed. And recently, the Government of India and MCI has increased the number of seats, PG seats in each and every institution. And now many teaching institutions, they are admitting more than 70 and up to 100 PG students per year, making it difficult to follow the MCI norms for teaching PG students. And last but not least, the lack of uniformity in teaching process. among different teaching institutions. Like one medical college is a private medical college, and other college is a AIMS. There are so many differences there in the teaching process. So the MCI norms are followed in the AIMS, PGI, SGPGI, and newer AIMS. But the private medical colleges or the now in recent past, government has opened the medical college in the district level also. So teaching process is not equal, uniform in the all over India. Thank you.
Okay, so that's the situation. But of course, I also have in the background that MCI has become getting tougher now with respect to the administrations, with respect to even recognizing the PG seats. They may be allotted the PG seat, but recognition of the PG seat is made more tougher now. That's a very good initiative from Medical Council of India. And just to, of course, share with our colleagues from UK, we don't have a singular body like the Royal College which can control the medical education, especially the postgraduate education, and we are under the overall control of Medical Council of India, which has control over all the specialities with respect to the medical education. Let me go to Dr. Muralidhar Joshi, the president of ISA. We heard that some of the limitations that we are not able to implement also. Can you expand on this? Because you have been in different, for example, you were trained in PGI, then for a brief period you were in private practice also, then you have worked in different corporate setups. What is your take on Dr. Bhargav's opinion?
Sir, I concur that Dr. Bhargav and Dr. Giri, what they expressed and all. Difficulty, sir, but what happens is every difficulty comes with an opportunity. So that's why I look at it. Like every challenge becomes an opportunity. What happens if the teaching is the only difficulty, say for example at this stage, I would like to have a common pool from Medical Council of India about the maybe a constant lecture maybe between 4 to 5 every day by eminent faculty across the country. That probably that's not a problem at all, faculty. But okay, hands-on skill and all those things, probably we need to have more mannequins and all those things because we can't do I should say experiment on the patients and all. It's not fair, it's not safe. But we can do it to mannequin and all those things. But there are always, or probably we can have more refresher courses. If you ask me, as Dr. Suresh rightly mentioned, some institutes have been good opportunities, good facilities, but some institutes there's some difficulty. We should be at least ISA point, if I would like to say, till the government takes decision about that one, we should have more refresher courses like we already have the postgraduate, the PG Excel, that's what we say. Postgrad training and all those things, hands-on. Some institutions they got faculty who can train them in difficult way, but some institutions do not have that kind of faculty, or they don't either have a faculty, but they don't have the access to mannequins and all those things. I think it's such a huge country. India we call it subcontinent. It's going to be variable performance and all those things. Probably, I think probably we should be working on definitely from ISA point of vision point of view, and probably I would take you as the academic chairman. We should work on some kind of model refresher courses across the country so that at least we can end up with a uniform training as a professional colleagues. I'm just giving it a government of India has some difficulties, it will come and all that, that's fine. But somebody who is going to clear the exam this year, what do we do with that boy? The question is, I think at least ISA should work in this direction to make it uniform training with its own capacity, which is possible. Definitely, ISA is one of the largest body in the world right now. I think our Honorary Secretary Dr. Naveen Malhotra also agrees. I think I can see his nodding over that. It's possible, Vice President Dr. Suresh Bhargav and you and all. Sir, is it possible? Can you do it like something like that? I'm just opening up myself. You tell me, sir.
Yeah, that is true. That is true, Dr. Joshi. Yes, we have not lagged behind. We have taken responsible decisions because we cannot depend too much on the Medical Council of India and the management of the various institutions where we were. It's also imperative that we as specialists, we as an association, we also have our own interests and see that education goes forward. So in that regard, actually, I do say there are good things happening, but there could be problems in implementation. That's ultimately the thing. And I am sure the things can be corrected. And as you said, IS has taken the initiative. And now I'll pass on that most important question to Dr. Naveen here. What have been the initiatives and projects overall from ISA for improving the skills in anesthesia practice? Dr. Naveen.
Thank you, sir. I'm happy to share that there are some good projects going on, and with all of us working together, some new projects are coming up. So as of now, ISA regarding skill management and skill enhancement is focusing primarily on hands-on workshops. And as many workshops are required by our branches at city level, state level, or national level, they are simply granted. Our motto is any academic or any clinical activity under the banner of ISA will get a nod, finances will be arranged. And these workshops are open, especially focused on the postgraduates as well as the freelance practitioners. And during our national conferences, we have more around 15 to 20 workshops. And they are in all specialties, all fields of anesthesiology, and sometimes they are overbooked also, and we have to double the number of halls and double the number of faculties. I'm happy to share that ISA has got its own modules for the research methodology workshop as well as airway management workshops. And soon, especially in this COVID pandemic, as Dr. Muralidhar Joshi was saying in his talk about the ISA National Task Force on COVID, there are clinical coordinators and there are training coordinators. So we are almost finalized our module on mechanical ventilation for this ISA National Task Force during this COVID-19, where we have been requested by government authorities to train not only anesthesiologists but also other clinical specialties also, like internal medicine, chest and TB, respiratory medicine, pediatrics, and also as a refresher course for our anesthesiologists who are working in district hospitals and civil hospitals. Scholarship, more than 20 per year. ISA, NEON, inland and international fellowships, they are also going on. And there is a provision for extra grant for any academic activity under the banner of ISA. And as we share amongst ourselves, and I'm happy to just pronounce it, that our motto is minimum uniform level of anesthesia teaching and training across the country in all medical colleges, in all cities. Uniform minimum level of anesthesia teaching and training across the country in all medical colleges. And the only aim is improving the patient safety as well as quality assurance. And some more projects are lined up, and I'll open up during the course of our talk.
Yeah, that's great. That's a very, very great insight into what has been happening in the ISA in the recent past. And of course, we have to thank our previous GC members of last up to 20 years ago also, because all these started about 20 years ago. And we have Dr. Venkatagiri. He was also a twice GC member and the Honorary Secretary of ISA, and he is now President-elect. Can I request him to highlight some other skill-oriented programs that have been part of ISA?
Thank you. The first skill-oriented program of ISA started with, if I'm right, from the WFSS sponsored CMEs. We had WFSS sponsored CMEs passed by ISA National. It was originally for the places which had no medical colleges to improve the knowledge of the practicing anesthesiologists, because we were always for improving the skills of anesthesiologists. That was, we had 8 topics, people coming from the state and outside give the talks. Once the WFS stopped that, we started our own, that ISS sponsored CMEs, and we were initially 10 CMEs per year, now we have increased to 20. There's not only CMEs, now people are more in demand for workshops, and people are doing more of workshop because we develop more clinical skill by doing it by hand. So these are things which we do for the practicing anesthetists. For postgraduate students, we do the ISS sponsored CMEs and PG teaching programs both in state level and in the zonal level we are doing it. And for 2.5 days to 6 days, a PG teaching program sponsored by ISA we are doing in various places, both in the state level and zonal level. For skill development of the PGs, we have the Inland Fellowship, ISA NEON Inland Fellowship. More than 75 postgraduates have undergone this Inland Fellowship in different institutions of excellence within India. And they have developed both hands-on training in this. And we have now international fellowship also. Last year we had 1 and this year 2. The new PG past candidate will go to another institution in another country and work there and see what's happening in the other country and come back. and use this knowledge for things. More than we have WFSA CMS in India, around 10 institutions are giving. We have the WFSA program for about 6 months in different hospitals, in pain, in cardiac anesthesia, thoracic anesthesia, in chronic pain, in critical care, and regional anesthesia and pediatric anesthesia. These are the academic programs ISA conducting for improving the skills of anesthetists both in our country and outside, both the PG trainees and the those who have passed their postgraduate training. This is in short and in a nutshell about what we do for improving the skills of the anesthetists in our country and who are coming from other countries.
So just one point I wanted to highlight from what you were discussing with respect to the ISA sponsored CMEs. So we are encouraging our branches to take up this ISA sponsored CME, and number two is we are allowing them to have even workshops instead of even the CME also. It could be a full day workshop with our support, or it could be half day workshop with our support. All basically we are targeted towards improving the skills with respect to the various techniques and devices which are related to anesthesia practice. Now beyond we are only talking about the students now basically and youngsters, but we have got a burgeoning number of anesthesiologists from different parts of India, and many of them are into private practice. Dr. Suresh Bhargav, Vice President of ISA, do we have plans for these private practitioners also? Do we have some guidance or training that is available or mandatory to them?
Yes, practitioners are also benefited by participating in the ISA program as informed by Dr. Naveen Malhotra all across India. In fact, we have now a private practitioner forum under ISA banner, and we encourage programs directed to improving the necessary skills in them as per their needs. And also, in fact, we have started to insist on the communication skills to be taught to our members in all our programs. And this has become very important in view of the medical legal issues that have started rising in India. Recent past, there have been instances of assault and even kidnapping of anesthesiologists in India, and hence interpersonal communication skills among the consultants, patients and their relatives and other healthcare workers have been highlighted to them. Then in each of the ISA programs, we are teaching the importance of proper documentation and consents. Guidelines like minimum monitoring guidelines during anesthesia, fasting guidelines are being prepared by the practitioners for the practitioner by the ISA. And apart from the skill development, scheme for the welfare of practitioners are also discussed and implemented by ISA, like indemnity insurance scheme for anesthesiology by ISA, and few other schemes are also in the pipeline. Then financial aspects of the practitioner are also being taken care of by ISA through private practitioner forum, like RBG. RBG is which is to be implemented across India. The RBG is the relative value guide by which we can calculate the fees of the private practitioner in any surgery depending on the city he is working and depending on the surgery and the seriousness of surgery and depending on the duration of surgery. And like RBG, we has to be implemented across India to develop uniformity in anesthesia charges across the country. Thank you.
Yeah, that's so. So Dr. Mahajan, Dr. Gokot, and Dr. Alil could be wondering that there was some mention by Dr. Bhargav about some finance and practice remuneration and all. We also take it as a sort of a communication skill, because anesthesiologists per se have not been so open, at least in India, and we have been really the people behind the screen. So it has become necessary that we also become more active. So we develop a rapport with the patients, the surgical colleagues and everybody, so that not just the practice of anesthesia, skills related to practice, anything beyond that, including finance management, are also very important. So we are also trying, IS as a body is also trying to see that our people become knowledgeable totally with respect to that also. So I am proud to say that yes, ISA has done on its own some beneficial schemes for the members. But overall, on introspection, I feel we can also do better. And for example, we have again Dr. Mulidhar Joshi. He is a pain specialist. So is Dr. Naveen. It's both. It is headed by pain specialists. ISA is headed by Dr. Mulidhar Joshi and Dr. Naveen. Dr. Murli, can you please highlight the skill acquisition programs specifically related to pain? Related to pain.
So that's a tribute. That's a tribute, sir. Definitely, both me and Naveen, we concur. Yes,
We take it as a compliment.
Yeah. So you feel that is so nice.
No,
So nice.
it's fair. It's fair. But question here is because so what is happening is, at least from our country perspective point of view, because it's worldwide studies, we know about almost 22% of people have some kind of chronic pain acute pain at some point of time and all. It's there. Definitely, we have been working on that one. But if you just look at your professor in medical college, you know very well, as simple as that. The pain clinic across the country, and Dr. Ravi Mahajan also knows, is run by the anesthesiologist. In Dr. Ravi Mahajan also, like we had in PG and all those things. All pain clinics across the country is run by anesthesiologists, by and large. Any medical college, any teaching institution, and all those things. In that case, we need to empower. There was a difficulty at that time. Training was a problem. We couldn't train the people, and probably the faculty didn't have time to go to pain clinic also. These are local problems, I should say, local problems. But subsequently, the subset of youngsters who have come out and all those things, they're able to organize themselves, they're able to read on their own, and of course, they're going for the. See, we started doing some kind of training courses and here and there short courses. Then we had the fellowship program from the ISS, that Institute of Study of Pain and all. And recently in national board also, like with a lot of effort from Naveen, we can speak to Naveen about that one. Is there now we had a accredited program and we got DM in pain medicine. Actually, all the pain medicine activities started almost 1984, and the internationally 1974 it was started. IISP started 1974. India ISSP in India started 1984. They're 10 years lag. We had a difficulties and all those things. But at the end of the day, if you ask me, probably whether talk about UK or you talk about US, I think Dr. Ravi Mahajan will agree with me. Most of the Indian anesthesiologists, they take up pain specialty as an optional branch. Predominantly, that's why I keep hearing. Maybe Dr. Ravi Mahajan, he's smiling, he's smiling. Predominantly, I should say, like Indians who go to Western world, they take pain. Probably they're looking for identity and all those things. Maybe I think probably when you speak to Dr. Ravi Mahajan about this one, you can ask why exactly Indian anesthesiologists they go to like Europe or maybe to US, why they take pain specialty, what makes them feel safer, and why we should encourage this kind of thing more in India, because in India it appears to be it's going to be much more like, like people feel happy, like I have my own practice in my hand, I can plan my day. I can plan my day is a better word. Still the fear is there, surgeons might disown me anytime, but this is the what I think. But I think probably Dr. Ravi Mahajan can correct me in this aspect, and of course Naveen, you can speak to him about FNB and all those things. It's put a lot of efforts. Over to you, sir.
Okay.
Dr. Bhaskar, over to you.
Yeah. I understand. Yes, it is gained a lot of importance now across India. And of course, the training programs, workshops have also been increasing day by day with respect to pain. And now I will shift to our colleagues from Royal College, because first part I just wanted to give a brief information and share with our visitors about what ISA has been doing and what is the current status of training and skill acquisition in anesthesia in India. Basically, when I open up, I will also say, for example, I was also an aspirant to go to UK in late 1990s. And in early 2000s, I just went back to my email yesterday. I tried to check. Those times I had active Hotmail account. I had exchanged a lot of emails with the Royal College, and we had the ODTS program and in fact, I did attend a program in British High Commission in New Delhi in around 2000 because there was a sort of a program to guide people interested to go to UK. That also attended. And of course, when I took over as editor of IJ in 2013, and I exchanged a few emails with Dr. Mahajan, because at that time I thought we can have interaction between IJ and British Journal of Anesthesia also. So it's good that now we have come back. This is a good program it augurs well for the future of both IJ and the ISA and Royal College. And I also went to the website of the Royal College. I did take a screenshot, but anyway, I thought we can just discuss it. I found this tab, training in anesthesia and working in anesthesia and flexibility in training. And this attracted me because we are part of the British colony. We were a British colony, and we had strong tie-up with respect to education in all the fields with the UK. And Indian students, medical personnel, and even anesthesia students, and everybody has been going to UK for long. And they have gone for training, and many of the times they have stayed back in UK to continue their services there. And the most important reason ascribed for this is because not just employment opportunities, mainly because the skill sets that are acquired in UK are very good, and our colleagues are very happy to practice the quality of anesthesia in UK. So I just request Professor Mahajan, can you expand on this? What is the status of Royal College? What is its stress upon the skills in anesthesia practice, first of all, before we talk about the openings available for our students in UK?
So thank you. Thank you for asking me to explain that. I think basically anaesthetists are doctors first and then anaesthetists later on. So doctoring in itself is, whether you call it a skill or a profession, I think maybe the words are getting used in a very sort of mixed manner. But what you require to be a doctor is knowledge, of course, and whether you're a specialist or not, some skill set and attitude. And so you have some technical skills and non-technical skills bundled up. And your personality that you grow within your profession, that gives you the attitude, of course, technical skills, and then the knowledge base. And I think what you will see, one of the things that we do, which is the Royal College does for training in anesthesia in the UK, is to set the curriculum. We set the curriculum. It's not up to the universities or individual hospitals to set what they will teach or what they will train people in. We set the curriculum, and that curriculum has to be met. And that's the GMC requirement, which is the same as Indian Medical Council. So our curriculum is approved by General Medical Council, and General Medical Council then provides the accreditation which recognizes you as an independent practitioner of anesthesia. So the two organizations, General Medical Council and Royal College, are interlinked in that way. So we develop the curriculum, they approve it, and then that curriculum then goes out to various hospitals or organizations. Now we call them schools of anesthesia. Now that's an important concept, because somebody mentioned earlier on in discussion that in India, you've got hospitals which can have varying level of expertise that they can train people in. So some hospitals can train you in certain things, but not maybe neuroanesthesia or cardiac anesthesia or some advanced stuff or intensive care, but others can. So that is, we in the UK, we also have some teaching hospitals or tertiary care centers which will have some specialized services, but then district general hospitals who may not have those specialized services. So what helps is that you have a network of those hospitals, and with that network, you create a school of anesthesia. And within that school, all the trainees, they are part of that school. And school makes sure that every trainee who is entered into their scheme gets through the whole curriculum, which has been set by the Royal College. And so for this part of curriculum, you may have to go to this district general hospital, but for that part of curriculum, you may have to go to tertiary care center for a little while, or pain center, or some specialized center. So I think how you adapt the existing facilities to create networks, and the networks then are responsible for imparting training and making sure that the training is given, is something that we have learned in the UK to do, and we're doing it currently. Previously, about 20 years ago, if you were a trainee in the UK, you would independently seek those kind of training opportunities by seeking jobs in different hospitals to get that curriculum. So that's how a uniformity is maintained in terms of training. And I think you're absolutely right. I came to the UK, and that was one thing that I realized, Chris, in the UK and stay here or train here. That is one of the reasons, definitely. And I think, I mean, India is at the right places is professional standards. So in terms of education training, so you have curriculum, exams, of course, everyone has to take our exam. And that sets a little bit of standard in terms of examining knowledge base, but also some skill set, but not every skill you can examine, and some of the attitudes. But then the accreditation process by General Medical Council will look at knowledge, skill, and attitude. The other side of Royal College is maintaining professional standards. So I think guidelines were mentioned earlier on, some uniform practice advisories were mentioned earlier on. And those are the kind of things. So we have guidance of provision of anesthesia services, which sets the standards that if you are providing services for, let's say, emergency surgery or obstetric surgery or gynecological surgery or neurosurgery, these are the standards that you got to maintain. And those are evidence-based. They are NICE accredited. So therefore, they are uniformly, they have to be adopted. So any accrediting body, whether that's the college or some care quality commission, if they go and inspect that hospital, which in your case, in Indian case, would be Medical Council of India, they would be making sure that those standards are met. Otherwise, you won't give the accreditation to that hospital. And I think those are the kind of things where we get involved. We do not regulate. We set the standards, and then it's up to the regulatory bodies to make sure that they are regulated. And it's the relationship between the college and the regulating body, which is very, very important. So I was encouraged to hear earlier on that ISA is developing that kind of relationship with Medical Council of India. I think that is the understanding that one needs to work on going forward, so that it doesn't end just with the COVID pandemic. So that's an opportunity, I think, a huge opportunity.
Yeah, thank you, sir. In fact, COVID is an opportunity for us because the government of India has realized the importance of the field of anesthesia, because we are involved in intensive care in many of the institutions, especially we got high density exposure in places like New Delhi and Mumbai and Ahmedabad, and it is us who are being exposed, and we are being recognized. So we hope in ISA, we hope that our push for a greater coordination with Medical Council of India will bear fruition now. And I'll go on to Professor Grokot here. So we had the basic discussion about the way the regulation of the education related to anesthesia is taken up in UK, and we service the GMC there. So now I want further details from you at the basic level. In what way you propose for skill enhancement specifically for Indian specialists? Like if somebody is willing to come from this place to learn some techniques and higher skills in UK, what way you can guide them, number one, and is it purely in terms of training alone, or they can have training along with jobs, or both of them can go together? This is my first question. Once this is over, I'll get back to the second question. Please go ahead, Dr. Groper.
So I think that's a difficult question to answer, because we are in, for more than one reason, in such a position of volatility at the moment. So we have, over the last few months, we've had COVID play out, which has been a huge disruptor, both in terms of our acute services, but also I think in the way that we are thinking about services and who does what, which medical professionals both doctors and non-doctors do things over the years to come. And that's playing out on a background of our leaving Europe, which looks like it's, I'm pretty confident it's still going to happen. And so our relationships with the rest of the world are changing radically. And we've had an arrangement as part of the European family in the EU over the last couple of decades, 3-4 decades, whereby increasingly our training and credentialing was aligned with European training credentialing. And so we have taken many trainees from Europe and absorbed them into our training programs, and then they've become senior colleagues alongside us. And I think it is less certain how that will play out. I think it's highly likely that non-EU medical graduates will have easier access. And I'm speculating. Ravi can correct me; he has more knowledge of this, but I'm speculating. But I don't think we know, and I think it is likely that there will be more opportunities for non-EU graduates to join our medical workforce, both as trainees and as senior colleagues. And I think one thing that we've worked out in the last 3 months is that we probably don't have enough doctors to do all the anaesthesia and intensive care that we need to get done at the moment. And that means we need to think more broadly about how we can be flexible within our own workforce to allow different people to fulfill different roles. And the example that you've already quoted is the anaesthetists who have stepped up because of their skills to support intensive care specialists. But I think we're going to be, the challenge of COVID is not going away. We have to restore normal services. I think understanding how non-medical professions will contribute to anaesthesia, how anaesthesia will contribute to critical care. I think we're in one of the most dynamic situations we've been in for a number of years. And so to be concrete in my answer is very difficult, but I think there are likely to be more opportunities in the years to come because of the two factors, COVID and us leaving the EU that I've just mentioned.
Yeah, that I understand. I would like Dr. Mahajan also to come in. I'm talking in terms of post-COVID scenario also. What had been before COVID and what would be post-COVID also, because before COVID, in the last 2 to 3 years, especially post-Brexit, we understand even in India that there has been an attempt, and the efforts were on from UK to recruit doctors, especially anesthesiologists, emergency physicians, and psychiatrists and all. And in fact, we had a few teams come from representing some NHS hospitals in UK. They were visiting India. They have been visiting since last 2 to 3 years. They have been holding interviews in different cities across India. So that was the status. So with respect to that, and on expanding on that, I just wanted Dr. Ravi to come. So do you think post-COVID, such a program will become more stronger, more and more NHS units can come to India and get our own colleagues to come there, youngsters to attend? And are there any age limits of experience, and at what levels of experience we can have openings? Simultaneously, they can also have training in UK.
Sure. So, I mean, the Royal College gets involved only in the conversations, but the policy makers in this area and the regulator, of course, is General Medical Council, because when they decide on policy, it's not only about anaesthetists, it's about every other healthcare worker as well. So it's about nurses, it's about doctors in other specialties as well. And so immigration is the other side of things, and then Department of Health. So Department of Health certainly has realized that we need more doctors in the short term. In the long term, UK needs to train its own workforce because we're outside the European Union now. We're also we also realize that the traditional sort of source of UK could rely on at one time, that workforce is changing as well, in the sense that many people who are coming, they are coming, as you say, for a brief period of time. They want a certain skill set, but then they want to go back and practice. So that's not a workforce solution, a long-term workforce solution for the UK. So that's the current thinking of the Department of Health. But certainly in the long term, they want to grow local workforce, which is what any self-reliant country should be doing. In the short term, of course, there will be capacity, and of course, there will be more opportunities. Now, where it is going to be a barrier to cross is that it is law in the UK that if you've got to decide or touch or go anywhere near the patient and participate in patient care, you've got to be registered by a General Medical Council. And as you would see, that's where the PLAB comes in, that's where ODTS schemes came in. Currently, the International Medical Graduate Scheme, so they operate under that framework. Currently, that is still, we are still in the era when we are part of European Union. So that process is easier for European graduates, and that process is quite cumbersome. I won't say difficult, but it's cumbersome. Lots of paperwork and lots of activity barriers that you have to cross before you get registered with General Medical Council. At a very junior level, you just have to clear PLAB and you can register. But for its already trained anaesthetists, you have a more paperwork and cumbersome procedure to go through. So currently we are having conversations with General Medical Council as to how we can make that smoother and easier. Now, one of the problems that comes there is, as highlighted earlier by Dr. Malhotra, that the variability in the system in India is such that if you are MD from, let's say, AIMS, or if you are MD from somewhere else, in a remote area, how does General Medical Council make a judgment as to these two people are equally trained? So therefore, and they currently don't have an exam, like in America you have FMGMS that you have to cross, and they would have different. So at present, we don't have an exam for people in anesthesia who want to come from abroad. They have to clear this before they can be accredited. And that is, and it wouldn't be advisable as well, because again, that's going to create another barrier. So I see that as a problem. So sooner that problem is fixed by, let's say, ISA and Indian Medical Council, by harmonizing standards. One could say, well, here is an exam, or here is an accreditation program, which meets the Royal College set of standards and the curriculum. And therefore, we could, as Royal College, can also say, yes, it looks like that the two programs run at parity. So General Medical Council might look at reducing the requirements for people to register. But I think once you're registered, finding a job is relatively easy because the job market is such.
Okay.
I'd like to comment.
That's good. Yeah, Dr. Naveen.
Thank you, Dr. Professor Naveen.
Naveen, before you come, I think I'd like to ask Alan and Mike, is that the reasonable reflection of the status, you think?
I think that's a very accurate reflection. And just maybe to mention the Medical Training Initiative, which the Academy of Colleges runs on behalf of the Home Office. And this is where you get a temporary visa to come and work in the UK. And people come from all over, but mainly from India on that scheme. And it's good because the trainees are well supervised. The college, we try and help by running new to the NHS training programs for these MTIs. So we're very keen that they're not thrown in the deep end and not just there as a pair of hands, as we would say, to do the clinical work. So they get new to the NHS seminars which they attend in the college, and they're now being run regionally, supported by our college. And the Royal College has also set up now recently simulation courses because that's so important in our training now. It's almost essential, and they get some simulation courses run by a few of our members, and that's a fairly new initiative which we're rolling out for the trainees who come on this initiative. Now, although it's a temporary visa, many of these can stay on, do some higher specialist training as well. But I think that is something I see that will expand, because although we're not designated a shortage specialty, we may become, when we leave the EU. So I think that might be an opportunity, and at least they're coming to kind of a coordinated training program, which is very similar to the program that our trainees get, rather than coming in on their own bat and just doing a trust type job, as we call it, which is just working in one hospital. So that's an opportunity. The other opportunity, just while we're talking about opportunities with regard to COVID, I think, is the amount of simulation done within the regions as opposed to centrally will increase. I know we've put in for a high fidelity simulator, which we got because of the COVID crisis and needing to train people in situ in their hospitals, as opposed to then won't be able to attend meetings nationally or even internationally. So just while I'm on that point. Thank you.
Naveen, yeah, thanks a lot. Naveen, you wanted to say something?
Yeah, thank you, sir, for giving the nice perspective of the overseas opportunities for Indian anesthesiologists in UK.
I just had a single question too. We are coming to the end only. I thought I think you are extending your time, Dr. Naveen.
No, sir is there till 8:30 with us. Absolutely no issues.
Okay, just
so this just because the comment to his thing about the opportunities, sir. See, and collaboration between RCoA and ISA. I must be. You have very rightly and very aptly expressed the available opportunities for the Indian anesthesiologist in UK, and Professor Anand further elaborated. So I think ISA and RCoA can have two types of collaborations. One, on working about the opportunities for Indian anesthesiologists in UK. And as we have already, I've already expressed that ISA now motto is that the Board of Governors and the MCI they form a uniform curriculum. Now ISA has taken up this ambitious project of ensuring its implementation and ensuring that there is minimum uniform level of teaching and training in the subject of anesthesiology across the country, in all the institutes. Yes, the institutes of excellence can have higher standards, but a basic level, a reasonable good standard of care, knowledge, skill, and training is imparted to all the anesthesiology graduates, refresher courses for practitioners, so that we work upon patient safety and quality assurance. For that, and me and President and other members of the council have been discussing about establishing an ISA skill lab. See, because as Professor Ellen was saying, that simulation and other speakers have said that in particular area, a particular subset of specialty training is available, and in some it is not available. So maybe initially one in each zone of India, because India is such a big country, and where I think ISA and RCoA can collaborate in all the academic and clinical activities, in teaching and training also, especially in this skill lab, where it can be a virtual training, and where it can be standards can be set, whether it is of specialty specific or a particular skill, maybe airway, maybe collaboration between Indian anesthesiologist and UK anesthesiologist for USG guided blocks, chronic pain blocks, and so forth. There is multitude of opportunities where we can have collaboration between ISA and Royal College of Anesthesiologists. We can also think of then, if the standards are met, a joint certification also. If we have such courses or such skill labs, so we can certify, okay, those who have attended this much sessions, they are reasonably trained, and we can certify also. And as you said, it's not only about clinics and academics, it's also about professional well-being also, about the stress management also, where we can both, the ISA and RCoA can collaborate. So these two subsets, overseas opportunities for Indian anesthesiologists, as well as having academic, clinical, teaching, training collaboration, especially in ISA skill labs. And how can we move forward, sir? Professor Mahajan and Professor Ellen.
So Thank you. No, I think we can, my personal view is that your second work stream, which is setting, having a joint sort of skill training programs, well, technical skills and non-technical skills. Also things like patient safety, quality improvement programs, leadership skills, all those things can be, we could have a package of program. I think these virtual openings now give us opportunity to reach out massively. People don't have to travel. So you could be having a reasonable amount of frequency. You could use some recorded material. So all those innovations can be put in place. And of course, you can also have a minima to jointly sort of accredit or give a certificate that this person has undergone this kind of training and has passed this kind of test to prove that the training material has been assimilated and can be practiced. So I think that can be set up without delay. So Alan O'Sullivan here is our chief of global partnership. I think these are things we can definitely start to work on. The other side, people coming from India and working in the UK, as I said earlier, already discussed, how it will pan out with the GMC, with the immigration, with all those things we do not have control over, but we can influence. We will have to see in next 6 to 12 months. So having a close collaboration on that will be very, very important. But more joint educational programs we can do, make sure people are, ticking those boxes of skill sets that they've got this, they got this, they got this, they got this. More material they would have to sort of show anywhere in the world that they've met these standards in terms of training at least. And therefore, that's only going to help in their overall professional development, but also if they wish to work abroad. So, Mike, Alan, if you want to say anything.
Just to say, I completely support what you say, and I agree with Dr. Malhotra about having accredited sites where you can do the simulation, and equally, because now we're having to rethink how we offer simulation and airway training and things, and a lot of it is going to be virtual, and it's something I think we could easily work with the ISA on delivering and accrediting that. And just with regard to simulation now, some of our compulsory simulation sessions, we are putting them online or doing them in a sim lab and stop and start and delivering them virtually, not having everybody in the room, and even doing the debriefing virtually. But it is challenging, but as you said earlier, every challenge is an opportunity.
I must here acknowledge Mike, sitting here taking notes, because Mike is taking on a reasonably big program, ambitious program on the behalf of the college, to see that after pandemic or even while the pandemic is still there, how the college in itself should be developing its strategy going forward. And global partnership will be a big opportunity sitting there. So I think that's a good place to start with, I guess.
Well, sir, can we hear Professor Mike? Can you hear Professor Mike?
He's late. Yes, sir.
Please.
The nature of the interaction we're having now clearly demonstrates that we can communicate much more effectively across boundaries. The technology was there, but we haven't really used it. And I think the technical challenges are clearly surmountable. The alignment of curricula and the alignment of criteria for assessment is pretty straightforward. The obstacles are actually those of politics and desire and the will to do those things together, and whether our shared organisations and our shared constituencies wish that to happen. I think that it's completely achievable to have these educational opportunities globally these days, and be able to pick the best of the teachers from around the world.
What I would foresee in the immediate future is, of course, it is difficult for us to get in touch with the medical council and implement all our ideas in toto in the near future, but definitely we can have a kickstart now itself in the way that we are talking about skilling now. So we can have, for example, airway modules, airway workshops or modules, online modules, just to know and spread the standards of airway management across the two countries to Indian population. And subsequently, once the COVID is over, probably we can have a more physical tie-up with RCoA. Similarly, across other training modules related to, for example, critical care, ventilatory management, and what is more common, the transthoracic echocardiography, TEE. So these are many areas where we can have a sort of fellowships which can also be mainly done online, and we can meet physically during our national conference. Normally, the National Conference of Indian Society of Anaesthesiologists is held during November of each year.
So thank you very much, Professor Mahajan, as of now, for accepting our proposals of moving forward for a collaboration between ISA and RCoA with the vis-a-vis the establishment of clinical skill labs and partnership between teaching and training, and we can move forward officially also on this. And yes, post-COVID pandemic, the opportunities, things will be different. Life is different post-COVID pandemic. Ma'am, Professor Allen, you have been an authority in airway management, and what is your take-home messages for, yes, you have rightly explained in your lecture, for airway management in COVID pandemic? Specifically focusing on COVID.
Sorry, specifically for
COVID patients.
Well, for COVID patients, I think I'll borrow a phrase that was in the guidelines, which was the SAS, get in there quickly and get out. And SAS stands for safety of the staff obviously involved, and safety of the patient. So safe airway management, know your algorithms and have a plan. Accurate as well. You want to get it right first time. In these sick patients who will desaturate very quickly, you want to use the most experienced operator, and you want to do it in a timely fashion as well. So accurate and swift as well. S starts for swift, in other words, timely, without rushing but without delaying. You have to make the decision early, and you have to do your RSI accurately and be prepared. You must have your checklist, you must have your equipment ready, and you must, as I say, do it safely.
Thank you very much. When we lost you audio about Dr. Bala Bhaskar, the question which I put was about the specific airway management in COVID patients. Over to you now.
Yeah. No, in fact, we have had few questions for all the participants. I think we can close this particular session, Dr. Naveen.
So we continue the question and answer sessions with all the speakers.
Yeah. So further to our panel discussion, I think we can have future exchanges. I think we can shift on to the questions which have been put by our visitors with respect to the presentations made by all the faculty.
Dr. Ravi Mahajan, around 5,000 viewers.
Well, so this tells you how the technology can be adopted. So it's an important conversation to have in front of 5,000 viewers. And for that reason, I think more we can do, in a collaborative manner, better it will be. So that prospect of collaboration excites me, because it means that the message can go out about the standards, about the safety, about the quality improvement, and the tools can be shared worldwide.
Right.
I think,
thank you.
Dr. Bhaskar, I think for the overseas faculty, whenever it's their time for to leave, let them leave. And if ISM members want to know more about that one, we can collect the questions. Then always discuss it almost a separate session. So I think thank you all of you, Dr. Ravi Mahajan, Dr. Ilan and Dr. Mike.
We got about 40 minutes. If they are ready to stay, we can do.
No, as long as they can stay, as long as they can stay. That's all I can say. As long as they can stay, as long as. So it's not a problem because we're just trying to exchange things out. All those. The idea is to move forward.
Yeah.
It's not an official meeting. It is a formal meeting. So it's more like that. How we can go about this one. And thanks a lot, sir. All three of you for being part of today's program. Thank you once again. Thank you so much.
Very much indeed.
Thank you very much. Thank you, sir.
Thank you.
Thank you. Please, Dr. Gopakrishnan only. Yeah, if there is a question related to critical care, how much benefit do we get in patients with prone position in bike?
Can you say the question again? I think it was a question about prone positioning. Is that right?
Yes, sir. Yes, about prone positioning.
So there's a lot of variation because we are short on data related to COVID. There's a huge amount of variation between different centres. I think the real novelty for us has been proning, individuals self-proning whilst awake. So people typically on CPAP or non-invasive ventilation who are offered the opportunity and choose to lie, semi-prone or fully prone. And we've had a number of patients who have avoided mechanical ventilation through that combination of self-proning and CPAP or non-invasive ventilation. And that's something I have not experienced before. In terms of those who are invasively ventilated, we've done a lot of proning consistent with what we would normally do in relation to management of ARDS. What's been unusual is the duration in terms of weeks, the number of episodes. And we've had some patients who have had more than 3 weeks of proning being put supine, proning being put supine on a 16-hourly timetable and survived. So that's been what's been different. And we've
got a patient who is already intubated and you want to make the patient prone. I think it's a practical suggestion and question that has been put by owners is that we should have as minimal number of personnel as possible within the ICU.
So what we did was separate the proning from the normal care. We had dedicated proning teams who were initially led by doctors, but actually ultimately not led by doctors. And they were from staff from theatres principally, but also some of the research staff who were not doing research and even some of our, and they would come and do 20 in a row. And then they'd go away for an hour, have a cup of coffee, UK. So have a dedicated trained proning team who became extremely slick and proficient at doing that maneuver.
Must say very low mortality among European COVID cases. Is it so, as per your knowledge, and what could be the reason?
So I think it will be very interesting understanding why some of the European nations have had high mortality rates, some of them had low mortality rates. That undoubtedly some of that variation relates to the way that we measure things. But equally, if you look at the national level observatory data about overall mortality, it's quite clear that some countries have seen no change at all in their background mortality, and other countries can very clearly see a substantial increase in mortality commencing in late February, March, and continuing through and declining about now. So there's definitely a difference between countries, and I think it's least likely to be due to intensive care. And that's not because I don't want to take any blame for it in the UK, but I think if you look at the deaths, the vast majority of deaths do not take place in intensive care. They're occurring in the community, in care homes, and some of them in hospitals. And I think it's most likely to be due to the behavioural elements of the public health management of disease, particularly in the early stages. So the degree to which track, trace, and containment strategies were used, and the behavioural response of the population. I suspect there will be cultural differences. There are socioeconomic differences. There's some good literature coming through at the moment about the nature of living environment and the built environment. The more people you have living in an enclosed environment, multi-generational living in an enclosed environment, therefore, the kids going out to school, the adults going out to work, the older people going out to another environment, the more likelihood you have of cross-infection, and the more contained that environment is, the smaller it is. The closer people are, the more they're going to be touching things. So I suspect it will be the public health and the environmental determinants that are actually quite a lot more important than the medical care determinants.
Yeah, these are some of the things which are pending to be clarified, because in India we are yet to probably reach the peak. So if you look at the displays put up by you in one of the slides, actually in Russia and in India, the number of deaths have been at this point of time revealed to be less only, but probably it will go up. So that's one thing which we should be waiting for anxiously. And a question to Dr. Ellen. Yeah, thank you very much. Dr.
I think Ellen,
she's there?
No, I think she's not there. So
okay, you can take up the question. A simple question. Somehow we have been having these webinars repeatedly about OT and ICU management, but still there is a basic question. They want to know whether intubation box or a plastic drape, which would be better in practice. Of course, you said we should be actually trained, first of all, to use an intubation box or even putting a plastic drape across the patient. So this is a question asked by 3 people. That's the reason I am forced to ask.
So the question is in relation to infection control around the time of intubation?
Yes. Yeah. Basically on that, patient comfort and, the operator's comfort and viral load contamination. Viral loads. So, yeah, please take up.
I don't know the answer. I would say, and I also don't know the availability of personal protective equipment for you in India. But I think our experience is that because so-called full PPE, so gown, mask, visor, gloves, proper mask is worn by people who are intubating, and because we've been very focused on our intubation strategies to minimize aerosolization, I think it's actually, I don't know if I should say this, but I think it's actually very low risk. So we've seen very little evidence of anybody being infected because I think we're so focused on safety at that time. So you might add a modest benefit from adding either a plastic screen or a box, but I'm not entirely convinced it's necessary because I think we're already extremely careful in the way we do it. The use of drugs and the use of senior expert individuals who are properly donned in their PPE, that I suspect it doesn't make that much difference.
Can I come in?
Sir, yes.
I think
yes,
Mike's absolutely right. So one of the investigators who looked at deaths amongst healthcare workers, Tim Cook, published this in Health Services Journal, and I mean, touch wood, and I don't want to speak prematurely in any way in this, but there hasn't been one amongst the anaesthetists or critical care specialists. I think the reason for that is that we have been very, very safety conscious right from the beginning, and I think it's important, as Mike has said, that the things around PPE, so it's not just PPE, it's what else goes with it. So the skill set, the other people who are supporting you, the drugs that you are giving, how quickly can you actually isolate the airway and stop aerosol environment. All those things are very, very important. So it's not just PPE. PPE is part of package, of course. And I think what Mike's mentioned, so the standards that we followed mirrored very closely to the WHO standards, and they are good enough.
Yeah, those Dr. Mahajan must be very encouraging words to our practitioners in India now that elective surgeries are being opened up gradually. So that has been a main concern. So what you would like to convey and the panel wants to convey is, as long as we are strict in having the PPE and keep ourselves safe, there is no risk of transference of infection. And in fact, there is a question for you, Dr. Mahajan. Can
I come in? Can I come in on that? There is another data coming out at the moment that in hospitals, the chances of doctors getting it from patients is less than the chances of people getting it from each other. So the social distancing amongst the members of staff and the careful sort of interaction because amongst ourselves there would be quite a few asymptomatic carriers, and how quickly can you get it from them is much easier. So the spread among staff is much more than the risk of spread from the patient to the staff.
Okay, it's great. So we let us all stay in hospital and keep working. There is a question from Dr. Krishna Prasad, sir, for you. Is the Royal College involved in counseling anesthetists?
That's a good question.
During COVID times. Yeah.
Sure. That's a good question. We are not directly involved in counseling anesthetists because we haven't got a service set up. But again, it's a question of whether if we were to set up that service, would we be duplicating the services which are already there? So we are involved in working with our colleagues in Association of Anesthesia, for example. They've got a scheme whereby they can provide counseling, but also within NHS and within your employing authorities, there are occupational health services and many other services that if one was to look for counseling, one could get. The Royal College of Psychiatrists certainly have set up some guidelines and opened up some channels so people could go through that. So we don't have it, but we can signpost people to appropriate counseling services if required.
Correct. Okay. Thank you very much. To Dr. Grokat, we have a question, and this is again widely discussed, but do we need to have a different concept in terms of design of the ICUs in COVID times as compared to the normal times, where we deal otherwise with other types of sepsis and critical care management of the patients?
I'm not sure. I'm not sure that we do. I mean, I think we need to be aware of, particularly aware of all the infection control issues. So we now have tape in a 2-meter line around all our beds, so that even now that we're stepping out of PPE, because most of our patients are not COVID infected, there's a sort of risk area defined around a bed in case, unbeknownst to us, a patient has PPE has COVID problems. I think the more important question is how we, in peacetime, when we don't have COVID, how do we manage our resources such that we can rapidly expand them when the next pandemic comes along, be it a coronavirus or an influenza or something else that we haven't anticipated. And one of the things that we organisationally as the college and with the Faculty of Intensive Care Medicine and others are focusing on is the notion of having a reserve workforce. So I don't know if you have something equivalent to, we have the Territorial Army, who are they're the part-time soldiers who, if a war comes along, would step up, and normally they spend a couple of weekends being soldiers during the year to keep their skills up. And we're looking at the notion that perioperative critical care, so the immediate post-operative care of patients in an enhanced care environment, is somewhere where we can keep the skills of the anaesthetists who are interested in perioperative medicine up in the critical care environment. So when the next pandemic comes along, and I think it's when, not if, we have both a physical space and a fully trained set of staff, medical, non-medical, nursing, allied health professionals, a lot. We have the capacity to rapidly step up because everything's there, the monitoring's there, the pumps are there, the ventilators are there, the whole infrastructure is ready. And I think that's a very appealing approach to both improve our perioperative care on an ongoing basis and have a reserve capacity for when we're hit by these unexpected, but to be honest, predictable strains on the system.
Okay, so we have a question from Dr. Bikram. Do we give higher doses? Is it required, or you increase the frequency of dosing of thrombolytics, anticoagulant management?
Yeah, it's a really good question, and I ducked it in my presentation. We have no evidence to support doing that, except for the inference from the fact that there seem to be an increased number of thrombotic events, both intrapulmonary microvascular thromboses and thromboembolic events. I can speak to our local experience where we moved everything a little more pro thromboprophylaxis. So we just the people who normally would have had 5,000 of heparin BD, we shifted them up to 3 times a day instead of twice a day, and all the way along the spectrum. So that the patients who are most sick with D dimers over 5,000, who were profoundly hypoxic, were starting to move into formal anticoagulation. Now, I don't know if we're doing the right thing. It's quite difficult because we have no evidence to support that, although some of those interventions are being evaluated in some of our national platform trials. But I think many units have tended to be a little more pro thromboprophylaxis than they might otherwise have been. On the other hand, one has to be nervous that the complications are rare, but they're catastrophic. So we have seen catastrophic intracerebral hemorrhage, and one has to remain very nervous about that and balance risks and benefits on an individual patient basis.
Okay, so thank you, sir. So I think we will take just 1 or 2 questions. Dr. Mahajan and you, I think it's a time to leave. Just to know, there is a question from Dr. Kiran. Probably your peak is over, but there is a risk of peaking of cases in India. How are the healthcare workers protected? In the sense, has there been an overall policy with respect to protection and with respect to the quarantine measures? What is the duration of quarantine, if at all it is allowed for healthcare workers like anesthesiologists especially? For example, we had a practice of allowing quarantine for 2 weeks for at least 4 to 7 days continuous work in ICUs. Now it has been restricted to about 1 week. Is there a policy like that in UK which was being used?
Not simply because of your healthcare activity. So if you're in a family where someone is known or suspected to have the COVID, then we have a national rule for everyone. So depending on whether it's a diagnosis or a suspicion, it's 7 or 14 days. But there's nothing. So if I do a sequence of on-calls, I can go home and I can be with my family. There's nothing like that. So it's only if we have clearly diagnosed or highly suspicious of COVID because of a fever and a cough that we would do some kind of quarantine activity.
Okay.
I'll just add on. Yes. Yes, I agree with you, Professor Mike, because COVID has taught us to be very, very flexible, and the dynamicity is changing. And as late as 18th of June, yesterday, our Ministry of Health and Family Welfare has released updated guidelines about this quarantine and other things. So yes, things are changing and they are flexible. And I take this opportunity to ask one more question to you, vis-a-vis the role of dexamethasone, which you touched in your slides, versus methylprednisolone.
So I think it is very. We've had this press release from the recovery trial of a very substantial benefit from dexamethasone given at 6 milligrams daily, either by tablets or intravenous dosing, and which looks to me highly. It's plausible, and the data sounds like it's good. But I think everybody's just a little bit concerned that we would be changing medical practice based on a press release and some tweets. Our chief medical officers across the 4 countries have said that they clearly believe this to be a good result and that practice should change, and I think practice will change. But it's just that, we're used to seeing peer-reviewed publications, and at the moment we don't have one. I'm sure it'll come very quickly, and that will settle this within a few days, I would imagine. But at the moment, we've got this very strong result that should be changing practice, but at the moment it's almost hearsay. It's press release and tweets. That's just a slightly uncomfortable situation. But I would definitely watch this space because the effect is so dramatic that it will be very important in terms of saving lives.
Okay.
I think Dr. Murli, Dr. Naveen, we can excuse Dr. Gopot and Dr. Mahajan.
Yeah.
There are a few questions. We can continue the next.
Yes, sir. Yes, sir. Yes, sir.
So it's been a pleasure. Thank you very much.
It was really indeed a pleasure to have you, Professor Mike Gopot. And I understand, in spite of your busy schedule, you were able to have the lecture as well as join us for a panel discussion. I officially, on behalf of ISA National, on behalf of my president, Dr. Mulidhar Joshi, Dr. Bala Bhaskar, Chairman Academic Committee, Dr. Suresh Bhargav, Vice President, Dr. Venkat Giri, President-elect, formally thank Royal College of Anaesthesiologists for partnering with Indian Society of Anaesthesiologists, especially to Dr. Professor Ravi Mahajan, you yourself, and Professor Ellen for sparing the time and partnering with ISA. Thank you very much.
Thank you very much for inviting us. Thank you.
Thank you. Thank you.
Thank you. So, Dr. Naveen, there is a very important question outside of academics.
Okay.
Will from one of our members, will attendees get any continuing professional development, continuing medical education points for this webinar?
Sir, I'll have to talk with our event management who is hosting this thing. If you can give me a list of the delegates, we can definitely send them e-certificates. The other question which immediately comes is about the creditors. ISA is working with the Board of Governors about the feasibility of having the creditors for such type of online activity, and some guidelines will come in near future. So I'll request Bharat to please compile a list of viewers so that we can send them e-certificates. We can send them. Because it's almost more than 3.5 hours of academic programs, and as of now also I can see that there are around close to 5,000 viewers are still online. So we can do this for our members.
Okay, so I think we can.
One thing, Dr. Bhaskar, Dr. Naveen, questions for both of you, both the medical colleges. Even if we give certificate from the, say that like so many credit hours, and somebody has to credit hours, the credit happens to be from maybe Haryana state or maybe Karnataka, or something like that. Will they acknowledge this web meeting, whatever the discussion is happening? That's what bottom we address.
Yeah.
So this is on the future.
Yes.
Future anyway.
Yeah, that's what. So it's a matter of time. I think they will be convinced.
It's going to future. I think both of you, because you like probably the Suresh and Dr. Venkat Giri, you have decided if this is the way it can go on for a couple of years. So we should do more credit points and all those things. But ISA cannot give on its own credit points.
No, sir, we cannot. We can give e-certificates.
We're not licensed. We're not licensed.
We'll only give certificates of participation.
No, that's okay, sir. But if we can just like open mind thinking, kind of thing. If we can get it through probably Medical Council of India, something like that, international webinar, a national webinar, a state webinar, wherever it is, as it is, maybe I think maybe Dr. Giri and Dr. Suresh and Dr. Bhaskar can guide us in that regard.
We'll explore, surely, because it's the future.
Because this is going to be order the day, sir. This is going to be like next 2 years, it will be like this.
You have to unmute.
To get this thing, there should be something either questionnaire at the end or that check whether they participate fully. There is a one thing. I don't know how they will question that. That is the only thing. Otherwise, now the time is only webinars. Some people may, for the purpose, just register and do not come. So, if you have some system to that, definitely we will have to answer that. What will you do? That is the thing. Or there should be some questionnaire at the end and that should be answered. Okay.
I think probably that degree, I'm just asking you, because I had a suggestion one of the policy member. He said, please limit the discussion, limit the webinar only 1 hour. 1 hour.
Yeah,
one to 1.5 hour.
It should be over in 1.5 hours, yes. The more than
1.5 hour. Probably can put a question, who's answer questions? Who's answer questions?
Yes. Delegate, 2 talks only 2 talks and discussion, 20-minute talk per discussion, that will be ideal. 2 talks of 20 minutes and discussion.
So basically 1.5 hour, we should, 90 minutes, we should be over.
Totally, it should be over in 1.5 hours.
Yeah. This is special meeting because we are looking at job opportunity for somebody else.
That is
okay. This is okay.
Sir, actually, this is the because we are long, but this is an historic meeting. First time between RCoA and ISA, and with so much of interaction. So I think questions will never end.
Lot of effort.
Naveen, I am not telling about this. Our regular webinars, which this is a special webinar with the Royal College of ISS. There is a special occasion, like a full day conference.
It should be like that.
Not we are telling a small one day CME like this. It's a full day 5-day conference. You have a 1-day match, 20-over match, and you have a 5-day series. This is a 5-day series we have to take.
No,
Now we are talking about the 20 overs.
I think I concur with that, Giri, what he's saying. That Suresh, you're smiling. That Suresh, you're smiling. I can understand. You're smiling. What do you think?
I will explore with our medical council regarding this credit hours, whether we can provide the credit hours, because in CME also, if some person is a CME, there is no question and answer in the last. This is not necessary. But in CME, they allot the credit hours to the participants. So, because in the COVID we cannot do the physical CME, so we'll explore it, and they should provide it. So, but only thing is that we should have the early registration for that.
Yeah, we work on that one. We work on that because whatever thoughts are there, because the question, we have to move on from here. We can't get stuck here. Just because COVID has come, is stopping all the scientific activities, it won't work like that. We have to evolve and things like that.
We have to move
I think
forward.
Dr. Bhaskar, Dr. Naveen, Pali, I think both of you can wind up at the poly whenever you feel appropriate.
Okay, I think
Bhaskar, sir, fantastic.
Thanks a lot. I have noted the questions. Probably we can answer our colleagues in private also. We can address the questions to Dr. Naveen, and you can send it to me also. So from our panel, our expert panel, we can also send the answers to them. Because already I think we have, it's 8:45 now.
You're right, sir.
So thanks for participation.
So we should thank you, sir. Sir, we should thank you.
Thank you. Thank you to Secretary and President, sir, for organizing.
Naveen, what of thanks, Naveen? Naveen, what of thanks?
Thank you all.
Thank you.
Thank you all.
It's privilege.
Thank you all.
Please.